الله الرحمن الرحيم. صباح الخير ومبروك لمؤتمر العالمي اللي احنا بنحضره كل سنة. يعني حاجة فخر بصراحة لينا كمصريين وكأساتذة، وطبعا مع دوام التوفيق دائما مستشفى بهية. السيشن دي الثيم بتاعها دايلاما in breast cancer management، وطبعا في اعلام كتير هيبقوا سبيكرز معانا في الجلسه دي، واحب اقدم الفيرست سبيكر اور دي بروفيسور ناديه مختار، بروفيسور of pathology cancer institute. She's going to present breast cancer in young females. دكتوره ناديه،
صباح الخير جميعا. أنا سعيدة جدا بوجودي معاكم، وسعيدة بإني دايما بشارك في مؤتمرات بهية. أنا بحرص دايما على إن كل سنة رب يدينا القوة والصحة إننا كل سنة نبقى معاكم ونشارككم في النجاح، لأن النجاح كلمة حلوة قوي، وإننا نبقى جزء من هذا النجاح شيء يشرفنا. النهاردة أنا هتكلم على pathobiology of breast cancer in young females. It's a bit of a gloomy subject, but we have to bear with it. And I will stress the fact on 2 points: myths and facts. myth اللي هو الأساطير، الحاجات اللي بتجيلنا من الأجيال السابقة. Some of them are true, some are wrong, and we have to correct them. And there are, of course, some facts. So let's move on and see what is the pathobiology of breast cancer in young females. So we'll start with the definition. What is the definition of breast cancer in young females? It's the breast cancer occupying or occurring in the premenopausal females less than 40 years of age. وهنقول very soon why the 40 year of age is the landmark that separates groups of patients. The incidence worldwide is not very high, reported to be 3% or so, especially in African Americans. However, it is still the most common tumor in women in that age group. Actually, we'll see what the situation is with us. It is unfortunately not very much aware because of the patient. Patient says, well, أنا صغيرة, no, cancer is for the old patients. Doctors again, they dismiss it, and maybe the radiologist would dismiss it due to the very thick breast cancer that can hide many details beneath. So, in fact, the story is a bit different in our area of the world, and this slide is courtesy of Dr. Imad Shesh. He is the director of the cancer hospital of NCI in Tajammu. And it is clearly here declared that the incidence of breast cancer in young females ranges between 19 to 24%. It's quite high, with an average of about 20%. I heard this morning that the incidences are about 14%, so it's still high in comparison to the rest of the world. And as you see, the blue columns here are even on the increase as they did their study from 2015 up to 2019. So what is the pathobiology and profile of this disease? And the data is taken from the pathology cancer registry that was out from the National Cancer Institute in 2016. Gloomy picture indeed, yes. Higher grade duct carcinoma, high in situ component, aggravated by pregnancy, and this problem of pregnancy will again talk about it in the afternoon session, inshallah. The tumors are very aggressive, metaplastic carcinomas, carcinosarcomas, very high on lymphovascular emboli, and the figure is 43%, and that's quite high. The stages are late, lymph nodes are positive in more than half of the cases, 54%. ER and PR not very high, 28%, but the HER2 is comparatively higher than the other groups of 22%. The triple negative again is high of more than 50%, with a very high proliferation index. gloomy picture indeed. Yes, the cases that are younger will show much higher expression of HER2 in their breast cancer, or they can be triple negative with a change of cytokeratin profile, very characteristic of that group of triple negative cases. I know you're not pathologists, but bear with me and I'll get you into the colorful world of pathology. These are very high-grade tumors, sheets and sheets, no tubule formation, no glands, no nothing, and a lot of necrosis up there in the upper left corner. Again, some other tumors that look very ambiguous, more like sarcomatoid phase or a sarcomatoid carcinoma, a lot of giant cells. And again, this is a metaplastic carcinoma. I've chosen this picture just to show you the two components that are there, the carcinomatous component with the tubule formation and the sarcomatous part. Again, this is a high-grade tumor. The immune modulation subtype of triple negative exemplified in this duct carcinoma with medullary-like features, in which no tubule formation, again, quite solid sheets and sheets of malignant cells intervened by a very high dense of lymphocytes or TILs. A lot of lymphovascular emboli, and that also affects the prognosis and the staging, with a high proliferation index in most of the cases. Now let's look at the traditional clinical risk factors. This we know: early menarche, late menopause, the use of contraceptive pills, no breastfeeding, and a positive family history, and radiation. But is that so? Because in many studies worldwide, not only in our area, that such risk factors may not be so much noticed in that age group of young females. A study that was published in the Asian Pacific Journal of Cancer Prevention showed that 30% of cases had only one risk factor, and another 30% with two risk factors, but all the other risk factors are not very prominent in that group. Actually, 23% of them had no risk factors previously mentioned before. Again, another study that we did quite some time ago, also showing that the history of breastfeeding was 80% in that group, and that the oral contraceptives were not all that common in that group as well. Family history was low, positive family history. So in fact, we feel that we have to reconsider the risk factors for this group of patients under the 40 years of age, because they are breastfeeders mostly, no contraceptive pills constantly, and the family history is very low. So we must think of other underlying factors, namely the genetic consideration. And here are some studies showing that the impact of parity on the breast cancer risk is actually, we have to separate two groups: those that are triple negative, and here the parity increases the risk for breast cancer, but it decreases the risk for other less aggressive tumors of older age groups, namely hormone positive tumors. So we have two scenarios with different risk factors. One is being increased by parity and the other is being decreased by parity. And, sorry, I need to go back. And we know that the prognostic factors, the bad prognostic factors, as we know them and know them quite well, it is the large tumor size, late stage, high-grade tumors, increased expression of HER2, and low hormone factors. All these are bad prognostic factors. But the young age at diagnosis remains an independent risk factor for the bad prognostic profiles in general. So we have to ask ourselves, what's with the age? What is the impact of age on that pathobiological process of breast cancer. And this is a diagram. I saw it on the net, and it's very ingenious because it tells the whole story. Let's review the normal mammary development. It starts with the stem cell, which then matures to become an early progenitor cell, and then matures to become the late progenitor, and lastly, the end of the cascade is the formation of the differentiated functional cell of the breast, with of course milk secretion and response to hormones. So this is the normal mammary development. Now let's look at the breast subtypes that is produced. If mutation then occurs in the early event of stem cells, it will produce a very aggressive tumor known as Claudine-Low tumor. And look at the signature. The signature here is mesenchymal. We talked about the sarcomatoid part of the aggressive tumors. That is why, because stem cells are then very rapidly proliferating cells. They are not functional, but they just proliferate to produce a mesenchymal signature, bad prognosis. Now down the cascade as well, we meet the bipotent progenitor, which attacks the breast cancer gene 1 and 2. This produces the basal type of breast cancer and gives the signature of basal-like signature. Down still, we get to the late progenitor, which hits the HER2 and produces the HER2 positive tumor. And look at the signature in general. There are no sharp horizontal lines between the diseases. That means that the change can be quite different from one case to the other. But generally, the HER2 positive tumors will either have hormone positivity or not. Lastly, the differentiated cells will produce the well-known luminal A and B subtypes, and the signature here is totally luminal. So you see, the signature and the expression and the types of breast tumors are quite variable. It's a very long process with many subtypes. So what about the age? I put here the scale for the age. Unfortunately, the younger the patient, the more liable to get mutations at an early stage of cell development. And the age is 40, which really separates the more aggressive types, which are attacked during the stem cell or the early progenitor cell formation, versus the other types that are above 40 and will have maybe the less aggressive forms. And that is why the definition of young is around the age of 40. And in fact, yes, it has been found that the mammary tissue in young females is very much enriched, very rich in immature mammary cell population. That means stem cells, progenitor cells, and they have even a massive increase during pregnancy, menstrual cycle, and lactation. And maybe we'll have a chance to talk on that area later this afternoon, inshallah. And this again has a peculiar cytogenetic and molecular biology profile, as there's a lot of chromosomal instability, and the activated epithelial mesenchymal transition that we talked about is very common in that group of patients as well as inactivation of immune pathways in general, with recurrent mutations in many genes that are being hit and maybe could be used as targets later on. We always find this triangle. A triangle has 3 sides, and there's always this 3-sided disease combining young age, immature cell of origin, and aggressive phenotype. They always go together. Unfortunately, this all happens during the early phases of females, the younger females. Particular genes and processes that are enriched include many genes that help in the profile itself. the receptor activator of nuclear factor kappa B, for example, the c-KIT, the breast cancer genes mutation type that we could test and use as target therapy, the mammary stem cells, and the progenital cells immature. So in fact, these can all be used as targets, and there are some experimental phases for this targeting this group of patients. Again, this group of patients has a strong stromal related genes. That is, there is a crosstalk very highly appreciated between the tumor cells and the microenvironment, that is the tumor infiltrating lymphocytes. And this is very, very much appreciated when we come to the application of immunotherapy. Is there a difference again between those two groups of patients, namely the young and the old? Yes, there is. Response to neoadjuvant chemotherapy, especially if the tumor is high grade. In our material at NCI, we found that up to 45% of the cases will reach a pathologic complete response. That is in comparison to the low figures of 10 to 15% in other cases of patients above 40 years of age. Excuse me. So there is actually a shift from the partial to the complete in this age group. Some photos again from pathology. See the tumor that was so cellular. Now after the neoadjuvant chemotherapy, the response is huge. Only very few residual malignant cells are seen, giving the score of 4/5, and that's good. Or complete pathologic response, where we only see fibrosis, inflammatory cells, nothing but that. And of course, it helps a lot if the clip is put, and this helps us to delineate the area of the tumor, which is otherwise not very apparent. Again, the tumor infiltrating lymphocytes in that group of patients is quite high. The two cases above show high TILs, and the two down there, poor TILs. And this diagram shows exactly this result, that whenever there is high lymphocyte infiltrate, if you look at the last bar, it shows that when the infiltrate is more than 70%, then the blue bar of the pathologic complete response is higher than the other showing less lymphocyte infiltrate. And that goes for all the T cells, the cytotoxic especially, and also the FOXP3 T cell percentage. And that, of course, opens the door to immunotherapy, where we boost the immune system to better fight the cancer cells. We unhook the T cell from the anchoring effect of tumor cells, and thus immunity is higher. Fighting of the cancer is great. We did a pilot study the impact of age on PD-L1 expression in these cases, and we found that it's not really significant. However, there is a trend for younger females below the age of 40 to have higher PD-L1 and thus response to immunotherapy. So let's review together the facts that we learned. Now, definition of young is now stressed the fact that it is below the age of 40, and now we know why. We use the 40 as a cutoff. And another myth that we should then correct is that it is low in percentage or low in frequency. No, we have figures as high as 20% in some registries. The triple negative or the HER2 positive, quite high in this group, and the risk factors should be revisited, meaning that the breast cancer is not a single disease, it's a multitude of disease, and today we just want to really press the fact that hormone positive tumors and the other non-hormone positive tumors should be treated quite differently regarding the age. The age, again, is a very crucial factor to be considered. The cell of origin is very important. It's all about the cell of origin. When you know the mother cell, you will know the disease. And if this disease of the younger patients is due to immature cells, it will behave aggressively. With of course higher, the response that is good in complete pathologic response, and this is because of the high TILs. And lastly, the immunotherapy in that situation would be more successful. Thank you.
Thank you very much, Dr. Nadia, for these dedicated presentations, and we will hold the discussions after the session. First of all, I want to thank the organizers of Bahia Conference, especially Dr. Amani Hilal, the head of the Medical Oncology Department in Bahia, and it's my pleasure to introduce Professor Dr. Hiba Zawahri, Professor of Medical Oncology, NCI. She will present optimum benefit for neoadjuvant treatment reading between lines.
Bismillah ar-Rahman ar-Rahim. Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. Dear panelists, dear professor and colleague, I'm very happy to chair the scientific session of the 7th Bahia Conference, and I would like again to extend my thanks to the whole organizer and the dear professor. I will talk about neoadjuvant and see how it is dilemma nowadays to choose what type of the neoadjuvant in early case of breast cancer. This slide? Okay, so my title is how to use the benefit of this neoadjuvant, and I add reading between lines, and I intend by reading between lines to use the best guidelines in our daily practice by our own mind and our own resources. Neoadjuvant is not a new approach. This is very historical, 20 years and more. It is aimed to make inoperable breast cancer to be operable and to allow breast conservation, and why not to treat metastasis, and later on to know the behavior of this biology of breast cancer. Nowadays, it is an art of neoadjuvant. The big discussion for each case is about how to choose neoadjuvant, and we cannot choose and apply this art because it includes many tools like chemotherapy, immunotherapy, targeted therapy, and endocrinal treatment unless we know the biology. And we know through doing that pathological complete response is very important factor. So we respect the biology more and more, and we try to do our best and complicate the things by doing and accumulate many agents to reach this pathological complete response. Nowadays, we do not separate the patient to responder and non-responder. We are working, the whole world are working on the non-responder. And because of this, and in many trials, they dedicate a new scoring system. So it's a breast cancer burden or residual cancer burden, where it is many subgroups, as if they are telling us patients who are not enter in the pathological complete response, we have to work and give them either more treatment or another treatment to help them in their future. We are tailoring the treatment according to precision medicine or tailored medicine. So while we are doing that, we have some tools to produce some product, and the product here is very precious. It is long survival free for the patient. So what we have patient comorbidity, we have patient age, we have molecular biology of the tumor, and we can apply according to some facts we have. But while we are doing that, and more recently, everybody advised us to do what is called the dynamic tumor response. In all new breast conferences, they are not giving the patient, or they are not advising to see the response after 8 or 6 cycles. They are trying to see early responder patient, so we can tailor more and fine-tuning the rest of the treatment. When we start endocrinal and we didn't have any response, we can shift to chemotherapy and vice versa. And I will tell more and more about this dynamic tumor response. They are using proliferating marker like Ki-67, and very short after induction period of less than 4 to 5 weeks, they do another biopsy and see how much it is affected by this neoadjuvant. They can follow the hormonal sensitivity in the tumor biopsy. They can look for circulating DNA and monitoring them during the neoadjuvant. And nowadays there is what is called the PET follow-up, and we will see in the few years what is called in the breast cancer PET-CR. Okay, so for example, in the triple negative, which is known to be a little bit aggressive tumor, and everybody, when hear triple negative, we decided to give chemotherapy in the neoadjuvant because we haven't any endocrinal treatment in this. But I ask myself, shall we give all this chemotherapy for all patients, and shall we give NET? Sometimes we would like to have a frontline surgery, and we have a big discussion about triple negative, at what extent of the tumor we go for upfront or we go for neoadjuvant. We cannot resist the guideline and the standard of care, and this is very famous for all medical oncology, Keynote 522. Keynote 522 comparing 4 agents of chemotherapy and again immunotherapy, and give us a result that if we give the patient carboplatin, paclitaxel, doxorubicin, cyclophosphamide with pembrolizumab, which is an immunotherapy, the patient may benefit a little bit higher pathological complete response, and this will reflect on her overall survival. We are happy, but the patient is not happy, because if we decided to do that, we will keep her 1 year for this immunotherapy. So shall we give her best survival by this very tough chemotherapy? Here is the survival curve, and it is very clear. And because of this survival curve, after 5 years of doing immunotherapy with chemotherapy, a group who respond and exposed to immunotherapy have 86% 5 years disease-free survival or overall survival. The other 81. Come to this curve and see with me. It's 5% after all this tough treatment, but we have to follow the guideline. So if we enter the patient with us in the discussion, she may choose another thing. And this is my thought, and this is reading between lines. Toxicity and the cost of this treatment for how long? Can we de-escalate a little bit when the patient enter in the complete remission? Or can we escalate if the patient is not responding? This is very important criticism to this study. And here, how many patients? This study includes 1,174 patients. And these 5% I calculated, it represents about 50 patients. So I have to treat 1,174 patients to bring a leisure and a pleasure to these 50 patients, something we have to think together. And if I am a breast cancer with triple negative patient and see this road map, I will be collapsed. How many drugs and how many steps I have to be exposed until I have a complete remission? So something we have to take care and see if it is small lesion, why not? All the world now thinking if it is T1, A or B, we can go for upfront surgery and keep the patient safe of this all toxic therapy and bring it on the adjuvant, but this is not confirmed in a clinical trial. Coming to the rose indolent good type, the luminal breast cancer, is again, I would like to remind myself this is very heterogeneous group of breast cancer, and it is not indolent as if it is appear. Sometimes we treat indolent with endocrinal treatment, and that's it is, but we found that early relapse or some complication. We have to know that this heterogeneity include luminal B. A luminal B is something between A and triple negative, or we have also triple positive, luminal with HER2 overexpression, and we refer it to as triple positive. And nowadays, all recent publication and discussion about lobular carcinoma, many trials for lobular, and there is a great interest all over the world for lobular carcinoma. And in this luminal type, it is very good chance to test for dynamic response by how much endocrinal treatment is affected. وعلى فكرة يا جماعة، واسمحوا لي أتكلم بالعربي، في أي MDT تريبل نيجاتيف سهلة جدا، HER2 سهلة جدا، نقف في بلوك كلنا ونتخانق على اليومينال، لأن if we choose chemotherapy for luminal we will somebody، وخاصة الجراحين هيقولوا حرام عليك يا دكتورة هبة، ما هنديه adjuvant، بلاش نديه نيو adjuvant وسيب العيانة تعمل عملية. وعايزه اقول لكم كمان ان اليومينال زي ما قلت يحتوي على بي ويحتوي على هير2 ويحتوي على بيزل سيل تايب which is مش هيتاثر قوي by the endocrinal treatment. ولذلك patient selection في neo adjuvant luminal is a little bit dilemma because we usually give it to stage 3 premenopausal high risk genomic, and if the patient would like to do a breast conservation. هو ده صح لكن غلط. احنا مفروض نعمله على proliferation marker and more biology in the luminal or more pathology زي lobular. والخناقه اللي بتيجي بعد كده، اتفقنا هندي كيموثيرابي، طب انهي كيموثيرابي بقى؟ anthracycline containing or not anthracycline for how many cycles. So it's a little bit gray zone and everybody in the MDT بيبقى خايف ومش متأكد قوي الديسيجن بتاعه صح ولا لا في اليومينال. طيب why I'm telling that this is Nadia Harbach, one of the figure of the breast cancer, and this is the last ESMO breast, projecting to us that if you go for pathological CR, this is the luminal and this is the luminal B. And she said that luminal B is like triple negative and HER2 overexpression. Part of the luminal B will enter by chemotherapy in the pathological CR, and only those group of patients will enjoy a long survival. Okay? So take care of luminal B and consider the pathological CR if you want to treat by endocrinal treatment. And she is telling us again in this curve that the luminal B, which is yellow, when it enters in the pathological CR, as I mentioned, it is good survival, but the group of patients who is less than PCR can be treated by second-line chemotherapy even. But in this presentation, she highlights a very important thing, that if you do Ki-67 and after 3 weeks you do another biopsy, and when it is low and is still low, this is the highest survival even though after 5 years. But when it is high Ki and become low, it may behave like low. So this is the dynamic and the biological response you can elicit it very early in the course of the disease if you start by endocrinal treatment in the luminal type, and you will continue with endocrinal treatment. But when it is high and is still high, the curve is lower down, and this is indication to the clinicians that you can shift to chemotherapy. So the idea of endocrinal treatment early upfront as a neoadjuvant is not a new one, and the National Cancer Institute Breast Hospital have been involved 3 or 4 years ago in a protocol called Sophia trial, and this was to test the operable luminal. All the group was operable, but luminal. Premenopausal and postmenopausal, they exposed to some endocrinal treatment, and we do the test and the Ki, and if it is responding, we continue on endocrinal treatment plus CDK4/6 inhibitor. If not responding, they go to surgery or chemotherapy. And here is the design of the treatment, here is the conclusion, and here is the publication and the year 2022. So can we go chemo-free in the neoadjuvant? And this is Carbella study, and I refer it to Carbella study. So what do? They compare the normal AC followed by taxanes with only endocrinal treatment and CDK4/6 inhibitor. Here's the pathological CR 13 and 80%, or I'm sorry, 18%. So pathological CR for chemotherapy is higher, but come to the other pie and see the clinical benefit. Clinical benefit is very similar. Either you give only endocrinal treatment or chemotherapy. I would like to refer to a very important, what is called ADAPT umbrella trials. The West German group now dedicated a study for all subtypes of breast cancer, but they insist to do, the investigator have to do a window of treatment, whatever this treatment, in most of the cases is endocrinal treatment or anti-HER treatment, and do another biopsy to follow the response and see they can give a proper treatment or not. So here in a luminal breast cancer, this is ADAPT cycle trial. Will they do biopsy, and if available, oncotype DX gene, 3 weeks only, and do another biopsy and see what happened to proliferation. When it is low, they go for endocrinal treatment only. Intermediate, they randomize the patient to chemotherapy or addition of CDK4/6 inhibitor. If it is high, they shift after 3 weeks to chemotherapy. So if we would like to see anything about HER2 positive سكة معروفة، مدرسة محفوظة، يلا هيرسبتين، يلا بيرجيتا، يلا نيو ادجفنت كيموثيرابي. ايه اللي هتاخده الست في الكيموثيرابي؟ انثراسايكلين، اندوكسان، كاربوبلاتين، تاكسينز. بقينا 6 لاينز اوف تريتمنت نيو ادجفنت. هل هناك مهرب for every T for all patient؟ اوكي. سو جايبه الكلام ده من فين؟ من 2 trial اللي هي نيوسفير trial and تريفيناس trial. all these patient exposed to anthracycline, taxanes and whatever. صح الباثولوجيكال سي ار عالي، وصح الباثولوجيكال سي ار بيأثر على الاوفر اول سرفايفل، لكن come with me to this very important schema. On the clinical T1 and B upfront surgery, we can de-escalate and the patient go for extended treatment or not، حاجة خفيفة شوية. لكن on the other side، وده كل عياننا T2 upfront systemic therapy, neoadjuvant chemotherapy, neoadjuvant dual blockade pertuzumab and trastuzumab. لو حظها السيء وما دخلتش في باثولوجيكال سي ار، ده انا لسه عندي تي دي ام وعندي residual disease and this is very complicated. Can we go chemo free even in HER2 according to the tumor size and according to the patient choice? We will see. This is article about small HER2. The key clinical question whether patient with a small HER2 positive cancer should be offered neoadjuvant or adjuvant trastuzumab chemotherapy. ليه؟ لأن كل الترايلز الكبيرة لم تحتوي على عدد كبير من العيانين عندهم 1 سنتي أو عندهم T1 tumor. So the clinician facing the dilemma of whether the potential reduction on the risk of recurrence in a patient group warrant all these toxic effect, if it is all these toxic effect, shall I give it on the adjuvant? Okay, so في 150 consecutive patient T A or B ما خدوش تراستوزوماب، كلهم هيرتو ولم يتعرضوا للتراستوزوماب. إذن this is the natural history of the disease. لو هم هرمون positive disease free survival 92%، كويس جدا 5 years. والهيرتو نيجاتيف والهرمون نيجاتيف disease free survival 91%، very similar وهاير than even لو جبت لهم النيو ادجوفنت او اديت لهم ادجوفنت. فالفاكت دي فتحت حاجه، انا I should give all the patient this very complicated treatment while we have the natural history of the disease is not that aggressive. نرجع تاني لازم نعمل genetic profile ونعمل some biomarkers that we select a group who will benefit and the group who will not benefit, and this is very important. Here is very recent publication or meta-analysis 10 years after adjuvant only paclitaxel and trastuzumab, no anthracycline and no pertuzumab, and the overall disease-free survival and no recurrence 96% and 99% not dying from breast cancer, overall survival 94% for all patients again. And this is very famous Sarah Tulani person when she projected this in the last ESMO or the year 2023. But in her talk she divided the patient to genomic high risk and low risk according to a new scoring system for HER2 DX كلاسيفيكيشن. عايزين نستفيد من وجود استاذتنا العظيمه الاستاذه الدكتوره ناديه مختار ونعمله روتين لكل حالات الهير2، لان هو ده دلوقتي بيقسم patient who need a dual blockade, patient who need more than dual blockade ممكن anti drug conjugate, and the patient who have a low HER2 and we will see. اوكي، في ادابت ترايل في الهير2 برضه جروب بيدوا 12 ويك بس تاكسول، مفيش حاجه الا 12 ويك نيو ادجوفنت مع تراستوزوماب اند بيرجيتا، and they found more than 90% pathological CR. الجمال في اللو very low chemotherapy، الناس اللي دخلوا في PCR ما ادوهمش adjuvant، يبقى بس العيانه خدت 12 ويك باكليتاكسيل والديزيز فري سرفايفل زي ما حضراتكم شايفين تقريبا 90%. الكونكلوجن في الترايل دي ان this is easy for the patient 12 weeks of weekly paclitaxel with a very good pathological CR and overall. and في الاستدي او الميتا اناليسيس دي حتى العيانين اللي ما خدوش adjuvant كانوا عايشين in a long survival. كلمة أخيرة على التريبل بوزيتيف. التريبل بوزيتيف ده من سنين أنا كنت مهتمية بيه، اللي هو بنلاقي في السلايدز ER positive, HER2 positive وكمان PR positive. Sometimes we find only ER, found PR، لكن it is a triple positive. triple positive ده كنا فاكرينه طيب وكويس واليومينال، لكن كل الاستدي بتقول لا، لان الكلونز هنا فيها some mutation and some resistant, and this in a very short الادابت ترايل قالت التريبل بوزيتيف ده مش هديله كيموثيرابي، مش انتوا بتقولوا وحش، انا مش هلمسه بكيموثيرابي، هديله تراستوزوماب versus TDM1 مع اندوكراينال تريتمنت واشوف اللي هيحصل ايه. لقوا اللي حصل ان اللي خدوا TDM في النيو ادجوفنت مع هرمونال تريتمنت هم ذا وينر. الباثولوجيكال CR اعلى حاجه والدنيا هي اقل من دقيقه واحسن من انه ياخد التراستوزوماب. وبعد كده قسموا العيانين الى ناس هتاخد في الهرمونال تريتمنت بتاعتهم الناس هتاخد الاندوكراينال تريتمنت العادي الادجوفنت مع سي دي كي 46 انهبيتور. وهنا هيبقى حلو جدا ان احنا نعمل لهم كل شويه صح بايوبسي وصح نتعب العيانه، بس هنفولو وات از كولد الدايناميك. This is my last slide and this is from the ESMO breast السنه دي، بتقول ان في اسكاليشن بس يعني ازود، بس لازم يكون عندي البيولوجي الصح. واكبر دليل على الاسكاليشن اللي هي الكي نوت 522. لكن في دي اسكاليشن لو انا لقيت دايناميكالي بتريسبوند والبروليفريشن بيقل، ممكن اقلل الاندوكراينال تريتمنت او اوقف الكيموثيرابي وادي اندوكراينال تريتمنت. and thank you very much.
Thank you, Professor Dr. Heba, for your fruitful presentation. Now it's pleasure to present Professor Dr. Rasha Kamal, Professor of Diagnostic Radiology, Cairo University and Conference President. She is going to talk about ductal carcinoma in situ. What does the radiologist add to the multidisciplinary breast cancer tumor board?
مش باين هنا. بسم الله الرحمن الرحيم. Ductal carcinoma in situ, what does the radiologist add to the breast cancer tumor board? Many breast radiologists look at breast cancer from a very narrow point of view. They might have a patient who is she's either asymptomatic or symptomatic. They do the examination, they write to the patient the report stating she has a benign or a malignant breast lesion, and maybe a few radiologists will follow up the patient to get the pathology results in order to see what they have written is correct or no. And they think that the story ends at this stage, but actually where they think the story ends is actually where the story starts. Definitely we begin to learn wisely when we're willing to see the world from other people's perspectives. And this is what happens to us when we start sitting in breast cancer tumor boards, hearing the oncologists and the surgeons. Our perspective to breast cancer totally changed, and I always find it a chance to thank all my colleagues in Bahia Breast Cancer Hospital and Asr Al Aini Hospital, because definitely I have learned so much from them. And in this lecture, I'm going to discuss with you DCIS from the perspective of a breast radiologist attending the MDT. Doing so, we'll answer 4 questions. How do we characterize calcifications? What should breast imaging radiologists know more about DCIS? Usually pathologists and radiologists sitting in the tumor board, they usually ask each other, are our results concordant or discordant? And lastly, how do referring physicians want radiologists to report DCIS? And answering each of these questions, we're going to show some common clinical scenarios encountered in the MDT. We'll first start by the first question, how do we characterize calcifications? To characterize breast calcifications, we should describe both the morphology and the distribution of this calcification. For the morphology, we have benign calcifications and the suspicious calcifications. Under the benign, we have a long list of benign calcifications, but we have one common feature which combines all this long list, is that all benign calcifications are macro calcifications, which means that we can see them without the need of magnification on mammography. Under the suspicious calcifications, we also have a long list, and one common feature which combines suspicious calcifications is that they are micro calcifications, which means that we will not see them in the mammogram unless we magnify. For the distribution, we have the diffuse distribution, the regional taking a wide area in the breast, the segmental following the ramification of ducts, the linear and the grouped calcification, which we used to call cluster calcification, and going from the diffuse to the grouped calcification, we are moving from benign to malignant calcifications. Our first case is a screening mammogram of a 55-year-old female. She had a typical rod-shaped calcification both in the CC and the mediolateral oblique view, and this type of calcification is very characteristic for patients who have plasma cell mastitis. If we do not look close inside the breast, we would have missed this calcification seen in the right breast. It's a grouped, or what we used to call clustered calcification with adjacent vascular calcification. They were biopsied and the pathology came as low-grade DCIS. If I'm sitting in the tumor board, I would never accept this as an explanation to the calcification I see, because looking at the mediolateral oblique view, the patient has pathological axillary lymph nodes. So directly we should recommend for a lymph node biopsy, and the lymph node biopsy came with being metastatic, and actually after excision this was a mixed invasive duct carcinoma and DCIS. Now we move to the second question. What should breast imaging radiologists know more about DCIS? DCIS cases presenting to the radiology department are either asymptomatic patients referred from screening units or symptomatic patients referred from the outpatient clinics with the typical presentation of a uniorificial, spontaneous bloody nipple discharge, and a portion of the cases will present with a palpable mass lesions. If you ask any radiologist, even surgeons and clinicians, what is DCIS, most of them will tell you that the vast majority of mammography detected DCIS manifest as microcalcification that follows the retroareolar ducts, either taking a grouped or a clustered pattern or a segmental linear branching pattern. But what we should know more about DCIS is that not all DCIS present with calcifications. We have 10 to 25% of DCIS appear as non-calcified asymmetry within the breast, and this is the contrast mammography of the same case, showing subtle enhancement corresponding to the focal asymmetry. Much less commonly, DCIS may appear as a non-calcified mass like in this case. We should also know that multiple lesions can occur in the same breast and in the contralateral breast as well. We have this case with an evident asymmetry seen in the outer quadrant of the left breast, and if we look close, we will find that this asymmetry shows the typical grouped microcalcifications. But if we do not look closely inside the breast, we would have missed another group, which was also a DCIS in the inner quadrant, and I think all surgeons here know that managing that a multicentric DCIS is not like managing a unifocal DCIS. Microcalcifications definitely are mainly seen on mammography, and that is why most DCIS cases are detected in mammograms. But the question is, do we see microcalcifications on ultrasound? And the answer is yes. In new machines, we can see the microcalcifications either in the parenchyma and inside the ducts, and if you apply the Doppler, we will find that this area shows increased vascularity. But what about the non-calcified DCIS? And the answer is yes. Again, we see them on ultrasound. They appear as non-mass hypoechoic areas, and more commonly they appear as dilated ducts with echogenic content. And again, when we apply the Doppler, we find intraductal vascularity. Even after what we've seen with mammography and ultrasound, we have to admit that MRI is still the modality of choice to assess the lesion extension in cases of DCIS. Pure DCIS usually present with any form of non-mass enhancement on MRI, and the common presentation is a segmental and clumped enhancement. Like in this case, we have a proved case of DCIS, and this is her MRI examination showing segmental enhancement radiating backwards from the nipple in the left breast. So we have to set up some rules in diagnosing DCIS, because DCIS follows duct ramification. So whenever we find calcifications or enhancement or an asymmetry taking a specific distribution in the breast, it should be taken seriously and it should be biopsied. This is an asymptomatic patient discovered in screening. She came for screening in 2021. She had a mass lesion in the right breast. Targeted ultrasound revealed that it was simply a cyst which was aspirated. In 2022 she came, but in this 2022 she developed something new in the breast, and that was microcalcification seen in the left breast. If we do not magnify, we would never see these multiple groups of microcalcifications seen in the left breast. And even without magnification, if we have AI in use, it will simply mark the area of the microcalcification, and this makes things easier for us. She was targeted by a vacuum-assisted stereotactic biopsy, and whenever we take this type of biopsy, we should document that the microcalcifications were present in the cores that we have taken, and the pathologist should also document the presence of calcification within these cores when he takes the cores of the patient. A biopsy revealed an intermediate grade DCIS. We move to the most important part of the lecture, and that is the radiology-pathology correlation. RAD-path correlation is the ultimate phase in the diagnostic workup of any patient after which management decision is taken. It includes the critical review of the imaging findings in view of the pathology reports. And to understand the different scenarios of radiological pathological correlation, we will put them in a table together. But this is from the perspective of a radiologist, because if I'm a pathologist, things would be totally reversed. We say we have concordant benign results when both results come with a benign lesion, and in this case, the patient should be put under follow-up. And we say we have concordant malignant results when both say we have a malignant lesion, and in this case, we have to proceed for radical management. We say we have discordant benign results when we as radiologists say this is a benign lesion, but the pathology report comes stating that this lesion is not benign, it's malignant, and in this case we should simply discard what we've written, and the patient should proceed to radical management. And for the discordant malignant pathologies, we stated that the lesion is malignant, and the pathology report comes with a benign lesion. And there's another example of discordant malignant lesion is that maybe we both say that this is a malignant lesion, but what the pathology does not provide an explanation for the radiologist, like the case I've shown. It is a DCIS, but we have pathological axillary lymph nodes. So this doesn't fit together. Both are malignant, but things do not fit together. And in the last two situations, we should have a stop, and we should revise what we've done. We should start revising, starting from revising the imaging findings, and we should revise the pathology procedure, whether the lesion was correctly biopsied or no. Should we do a rebiopsy or excise, and do we need to take larger cores or no? This is an example of a discordant benign results, and again, for explanation, we write in the radiology report that it is benign, but the pathology report comes with a malignant pathology. This was a 42-year-old complaining of right bloody nipple discharge. She had a heterogeneous dense breast, but there were no microcalcifications, no speculated mass lesions inside the breast. On her ultrasound, there was a tiny hypoechoic lesion, and in the radiology report, it was written that this was an intraductal papilloma, or an intraductal lesion, likely a papilloma. When she did the cytology came with a hemorrhagic discharge with mild to moderate atypia. And when we see the word atypia, we should stop here and revise what we've done. We started by revising the radiology, and when we saw the ultrasound, we said this might not be a benign lesion. It has irregular outline, and it's not typical for an intraductal papilloma. So we decided in the MDT that we should rebiopsy the lesion. And this time the biopsy came, it showed a low-grade DCIS of cribriform pattern, and the ER was positive. The biopsy report came with a low-grade DCIS. And in this case, we had to proceed for radical surgical management, and immediately when we decide this in the MDT, the surgeon would tell me, should I perform a mastectomy or a conservative surgery? And we would recommend for a contrast study to know the actual extension of the lesion. This was the small lesion that we saw on the ultrasound examination, but it was not only the lesion present, there were dilated ducts with related segmental non-mass enhancement, taking a long segment starting from the nipple down to the pectoral muscle, and the decision in this case changed totally to a simple mastectomy. This is a screening mammogram of a 65-year-old female. This is an example of discordant malignant. We say malignant, and the pathology comes with a benign pathology. What we saw in the mammogram was actually this obscured mass lesion, which looked more or less benign. But if we do not magnify, we would miss a very important finding in the right breast, and this was the microgroups of microcalcifications reaching down to the nipple. The pathology report stated that it is intraductal clonal epithelial cell proliferation that only involves a portion of the affected duct, and the result was this was fibrocystic disease with foci of ADH. In many cases of ADH, when they are surgically excised or we take a larger biopsy course, they turn out to be actual DCIS and not ADH. So we had to revise again, because we saw in the imaging was definite that there was a serious pathology in the right breast. But was the biopsy done correctly or no? We had to revise. When we went back to the imaging of the course, there were only 2 foci of microcalcification, and this is not enough for the pathologist to differentiate between an ADH and an DCIS. So we took another core biopsy using vacuum, and actually now the report came that it is an intermediate grade DCIS, solid and cribriform patterns with microcalcifications within the lesion. And we had to proceed for radical surgical management. And in this case, we did not need further imaging because already the calcifications were involving nearly all the breast, so the patient was a candidate for mastectomy. The last questions: how do referring clinicians want radiologists to report DCIS? The radiology report is considered the end product of radiologists. It is the way or the chief way how radiologists communicate with clinicians. On the other side, clinicians are considered the customers of the radiology department. Before attending the breast cancer tumor boards, radiologists are usually product-centered, which means that during writing a report, they mainly focus on a well-organized report, which is their product, irrespective of the clinicians or the customer's demands and challenges. After attending the breast cancer tumor boards, they become more customer-centric. They focus on the clinicians' demands and challenges while writing their report. This is an example of a 38-year-old with left breast palpable mass, which was diagnosed as inflammatory outside Bahia. When she had a left breast global asymmetry, and when we performed the ultrasound, there were microcysts, dilated ducts, and indeterminate axillary lymph nodes. We took a biopsy, and it turned out to be a high-grade DCIS. If I'm a product-centric radiologist, I would just write that there is a left breast global asymmetry seen both in the CC and MLO view, and that we have left axillary lymph nodes with a thick cortex. I would give the patient a BI-RADS 3 or a BI-RADS 4 accordingly. But if I'm a customer-centric radiologist, I will add to what is written above the actual extension of the lesion, the distance of the lesion from the nipple, the distance of the lesion from the skin, if there is skin thickening or no. And if I mention that we have pathological lymph nodes, I should state the level of affected lymph nodes and the number of affected lymph nodes. And I would recommend for a biopsy. And when in MDT, we know that the lesion pathology is DCIS, and I have seen indeterminate axillary lymph nodes, I will recommend for a second look ultrasound and biopsy. And in this time, I would recommend for a true cut biopsy and not a fine needle biopsy from the axillary lymph nodes. And I will tell the radiologist, the surgeon, that I need a further MRI study. And if we perform the MRI study, a product-centric radiologist will write that we have left breast segmental, heterogeneous, non-mass enhancement. It shows a dark T1, intermediate T2, and bright stir signal with restricted diffusion. But if I'm a customer-centric radiologist, I will mention the size of the lesion, whether the nipple is affected or no, and the distance from the nipple, the distance from the skin. And finally, to end my lecture, the implementation of multidisciplinary tumor boards enhances the communication between different specialties, and thus they definitely impact breast cancer care outcomes from diagnosis to management. Furthermore, tumor boards are a good chance for young radiologists to learn and for professionals to upgrade their knowledge. And thank you.
Our next speaker أنا هقدمه إن he's one of the very prominent breast surgeons in Egypt, professor of cancer surgery, dedicated most of his work to breast surgery. On a personal basis, he never missed a Bahia conference. In 2017, when we invited many surgeons in Egypt and many from Ma'had al-Awram, he was the only one to attend. Many followed, but we always respected him, Dr. Professor Sharif Naguib.
لا ثاني شكرا دكتور أشرف على التقديم الجميل ده. I would like to thank the organizing committee of Bahia Hospital and especially my very dear brother and friend Dr. Maher Hassan for inviting me over. I will try to present the idea that a surgeon has about the BRCA mutation and how this mutation could affect our surgical decision. To start with, BRCA means breast cancer antigen, and these are tumor suppression genes, and their mutations causes a significant increase in the likelihood of developing some kinds of cancer, mainly breast, ovarian, pancreatic, and prostatic cancer, and they are inherited in an autosomal dominant pattern. They are not very common. We see them in 1 in 500 to 800 of the normal population. They represent 2% of breast cancer patients at any age. They are found in 10% of younger breast cancer patients before the age of 40, and they represent about 10 to 15% of ovarian cancer patients. What is their significance? When you see a BRCA mutation in a patient, this could increase the risk for hereditary breast cancer by 35% in BRCA1, a little bit less in BRCA2. You will find that it increases the incidence or the risk of breast cancer by age 70 in up to 80% in patients with BRCA1, a little bit less in BRCA2. It will increase the risk of ovarian cancer by the age of 70 in up to 50% in BRCA1 and a little bit less in BRCA2. And it will increase the risk of developing a second primary breast cancer in about 60% of patients with this mutation. Now, when do we test patients for BRCA? Actually, there is no international consensus until today, and there is about 30 or more guidelines on who to test. Probably the clearest consensus guideline is the one by the American Society of Breast Cancer in conjunction with the NCCN. So, which patients with breast cancer should we test? Actually, breast cancer patients who have one or more of the following: if they develop their cancer before the age of 50, if they develop triple negative breast cancer before the age of 60, if they have 2 or more primary breast cancer, whether asynchronous, synchronous, bilateral, or multicentric, if this patient has a first-degree relative that developed breast cancer at a younger age than 50, if she has 2 or more relatives of the same side of the family with breast or pancreatic cancer, or if she has a family or personal history of ovarian, fallopian, or peritoneal cancer. Now, which women without breast cancer should be tested for BRCA? Actually, women who have one or more of the following: the first or second degree relative with breast cancer that developed younger than the age of 45, a woman that has 2 or more primary breast cancer in a single family member, or that has 2 or more relatives with breast or pancreatic cancer, or a woman that have a family or personal history of ovarian, fallopian, or peritoneal cancer, or if she has a known mutation of BRCA in the family. Now, what does the surgeon, what would this BRCA mutation affect the surgical decision in which way? Actually, the surgeon with BRCA mutation is concerned with the affected breast, the contralateral breast, and the ovaries. Now, regarding the affected breast, should we do a mastectomy or breast conservation? Actually, mastectomy is not a must. Mastectomy will only reduce the incidence of locoregional recurrence. Nevertheless, there will be no difference in overall survival or breast cancer specific survival whether you do mastectomy or breast conserving surgery. And this is a meta-analysis that appeared in the breast in 2021, and that was concerned with 23 studies involving over 3,800 patients, and that found that survival outcomes were the same whether you do breast conservation or mastectomy to BRCA mutants, but the risk of locoregional recurrence was lower when you did mastectomy. So if you look at the forest plots of this study, you will find at the top on the right hand side, you will find that locoregional recurrence was higher with breast conserving surgery. But if you look at disease-free survival, breast cancer specific survival, or overall survival, you will find that both mastectomy and breast conserving surgery were almost the same. And that was after 15 years. So mastectomy is not a must. It only decreases local recurrence, but does not affect survival. Now, what about the contralateral breast? Do we have to do a contralateral mastectomy? Here again, the same finding was discovered, and contralateral mastectomy showed no difference in overall survival or breast cancer specific survival when compared to only intensive surveillance of the contralateral breast. Nevertheless, it will reduce the incidence of contralateral breast cancer without affecting survival. And this is another meta-analysis that was published in 2014 and was concerned with 93 studies, and that found that contralateral prophylactic mastectomy decreased only the metachronous contralateral breast cancer incidence, but did not improve survival. Now, what about the ovaries? Risk-reducing salpingio-oophorectomy was suggested. It will reduce the occurrence of ovarian cancer in 90% of the patients, and it also showed a survival advantage, but its effect on increasing breast cancer, increasing breast cancer specific survival is controversial. This is a meta-analysis that concerned over 13,000 patients, and that found that risk-reducing salpingio-oophorectomy will lower the breast cancer risk among BRCA1 patients and the BRCA2 mutation carriers, and both breast cancer risk decrease was found statistically significant with salpingio-oophorectomy. This is another meta-analysis that was published last year, and that showed that risk-reducing salpingio-oophorectomy was not associated with primary breast cancer or contralateral breast cancer risk reduction, but it was associated with improved breast cancer survival. So as you can see, contralateral breast mastectomy or the affected breast mastectomy will not affect survival, while risk-reducing salpingio-oophorectomy will improve survival of these BRCA mutant patients. Now, is chemoprevention, does it have a role? Yes, chemoprevention using tamoxifen for premenopausal patients or aromatase inhibitors for postmenopausal patients for 5 years was found to decrease contralateral breast cancer risk and to decrease breast cancer-related mortality. Nevertheless, in BRCA1 patients, it is not effective because most of these patients have triple-negative breast cancer, which is unresponsive to anti-hormonal treatment. And of course, we all know the numerous side effects of hormonal chemoprevention. So to tell you the truth, the NCCN guidelines do not recommend chemoprevention based on BRCA1 and 2 mutation patients. Now, what about the normal women who don't have breast cancer? Does BRCA mutation affect the surgical decision? Actually, some authorities suggested bilateral prophylactic mastectomy or risk-reducing mastectomy for these women with BRCA mutations who don't have any breast cancer, and this was triggered by the decision of this very famous American actress called Angelina Jolie that found out she had BRCA mutation and who decided for bilateral mastectomy as a risk-reducing procedure. This will reduce the risk of developing breast cancer in up to 95% of the cases, and actually occult breast cancer was found in 11% of the specimens of prophylactic mastectomy. What about risk-reducing salpingio-oophorectomy? When should it be done? Actually, at the age of 40. Why do we do it? Because it will reduce ovarian cancer risk by over 90%. It will reduce breast cancer risk by 40 to 70%. And tubo-ovarian tumors, malignant tumors, were found in 2 to 10% of these specimens. So what is the optimal timing for risk-reducing procedures? Regarding breast bilateral risk-reducing mastectomy, it should be done around the age of 25 to 30, while salpingio-oophorectomy should be done around the age of 40, taking into consideration that the mean age at menopause is about 50. Does BRCA mutation affect prognosis? If you have a patient with BRCA mutation, will she have a worse prognosis than patients who have sporadic breast cancer? Actually, there is a conflicting evidence. Nevertheless, I found this meta-analysis that was published in 2020 and that included 36,000 patients, and that found that BRCA1 mutants had a lower overall survival, which was statistically significant, while BRCA2 mutants had a lower disease-free survival and a lower breast cancer-specific survival, and these were also statistically significant. So yes, BRCA mutation is a bad prognostic factor for breast cancer patients. Now, in women who are found to be BRCA mutants and who refuse risk-reducing mastectomy, how should we follow them up? They need to have an annual MRI starting the age of 25. They also need to have annual mammograms starting 10 years earlier than the first case in the family. So our conclusions are the following. BRCA1 and 2 mutations are rare findings in the general population, affecting 1 in 500 to 800 normal population. Their presence is associated with increased incidence of breast cancer, usually at a younger age and often bilateral, and also, well, let's not forget the higher incidence of ovarian cancer in these patients. The available options of choice for managing these patients are thorough observation and screening if they refuse risk-reducing surgery, or risk-reducing surgery if they accept, and chemoprevention is still debatable. So patients with BRCA mutation and breast cancer should be offered the following options, and these options should be discussed with them, whether breast conserving surgery versus mastectomy and the advantages and disadvantages of each, contralateral prophylactic mastectomy and its disadvantages or advantages, bilateral risk-reducing mastectomy and risk-reducing salpingio-oophorectomy with or without total abdominal hysterectomy. All of these should be discussed with the patient, and I thank you for your attention.
Thank you, Professor Sharif Naguib, our colleague and our friends. I was asked to introduce Professor Bahadir. He will talk about the potential of non-surgical management of breast cancer. It is a video session, it is a virtual, so we don't have to ask him anything. Otherwise, we should have criticized them and jumped on his shoulder because we are surgeons and we don't like the option of non-surgical management of breast cancer by and large. So we'll start the video session of Professor Bahadir. Can we start?
Hi everyone. Greetings from Turkey, from Istanbul. I'm so sorry not being with you there in Cairo this time. And today I would like to talk about the potential of non-surgical management of breast cancer. So why do we do surgery in breast cancer patients? The first aim is to do the local regional treatment to control the disease. And the second aim is to stage the disease by removing the tumor and the regional lymphatics, because according to the staging that we applied to these specimens, we tailored the adjuvant treatments such as chemotherapy, systemic treatment, and the radiotherapy. So far for the last 30, 40 years, we understood that not only surgery, but the systemic treatment has a huge impact on tumor. And when we apply this treatment as neoadjuvant setting, we saw that now in some subsets of patients and subtypes, we see more than 50% of the time with a complete response. So with having this potential in mind, that we can foresee that in future, more and more patients will have a complete response, pathological complete response, by using the new drugs on the pipeline. So here on this diagram, you can see that, especially in HER2 positive and triple negative cancer patients, now we see nearly 70 to 80% of the patients with a pathological complete response. So this is promising. So today's question is there any possibility to not do surgery in these patients? So there are two gaps in knowledge. First is how to determine the complete response accurately without pathological assessment of the surgical specimens, because this is important in order to understand what to do in the extended systemic treatment. The second question is, what is the long-term outcome if local resection is not done? So to answer the first question, there are some modalities such as breast MRI, ultrasonography, mammography, and contrast and enhanced mammography. So the breast MRI is so far the most common utilized imaging method in these patients. We saw that, yeah, it works, but the accuracy is not excellent. So in such subtypes like HER2 positives and triple negatives, the breast MRI would give us a more reliable the result in showing the the complete response in these patients, but it's not excellent. So again, in combination with MRI or not, contrast enhanced mammography also did not give a very satisfactory result to determine the pathological complete response in all patients. Still, we have a way to go to understand the complete response in these patients by having more advanced technologies, but not yet. So what about taking some samples from the tumor site, from the original tumor sites, after having the systemic treatment in these patients? So vacuum-assisted biopsy is one of the most common methods that we use, that we apply in these patients. So we also saw that by doing this vacuum-assisted biopsy, especially with the large bore needles, is better than imaging to understand the pathological complete response in these patients. But again, it's not excellent. So again, it was shown in some groups, not all groups, because so far there are 8 or 9 studies just studied this vacuum-assisted biopsy in order to understand whether it is accurate or not to understand the pathological response in these patients. Only few of them show that the false negative rate is less than 5%. And if you look in only the HER2 positive and the triple negative cancer patients, this false negativity is really low, is lower than 5%, but not in all tumor subtypes such as hormone positive ones. So again, another study showed that the false negativity rate is less when you look in the MRI and see the residual tumor is less than 5 millimeters, and if you take more than 5 samples, of course, and during vacuum-assisted biopsy. So there's no excellent method to understand the complete response by using the imaging only or combination of imaging and the minimal invasive pathological sampling. So what is the long-term outcome if localization is not done? So far, there's only one study, which is also small here, but this is the only study from MD Anderson. It's a prospective study, and I'm sure that most of you know about this study. They included only those patients who were older than 40 years of age. They included the unicentric invasive breast cancer patients, and only HER2 positives and triple negative breast cancer patients, which is understandable because they're really giving an excellent response to neoadjuvant systemic treatment. So they started to recruit patients in 2017 up to 2021. They started with 58 patients, but at the end, only 50 patients had an image-guided vacuum-assisted biopsy after neoadjuvant systemic treatment. And nearly half of them were HER2 positive, and the other half is triple negative cancer. In the beginning, before neoadjuvant systemic treatment, the initial largest tumor size was 2.3 centimeters. And at the end of the vacuum-assisted biopsy, they found only in 31 patients out of 50 patients, which is 62% of the patients, had a pathological complete response in the breast only by vacuum-assisted biopsy. That doesn't mean that they have a complete response because they didn't prove it by doing a surgical resection. So they did not do any surgery on these patients, only gave radiotherapy. So at the end of nearly 3 years, is a median follow-up, they found that the recurrence is 0. So 3 years of disease-free survival and overall survival, they found that it's 100%. So this is an excellent result after 3 years, but with the 31 patients only in this cohort. Another study, which is also having a very small cohort with 7 patients. Again, they included HER2 positive and triple negative breast cancer patients. This study is done from UK, and all had, again, accordingly, the neoadjuvant systemic treatment. All had no residual disease after post-neoadjuvant systemic treatment, image-guided vacuum-assisted biopsy, similar to the design that I showed in the previous study. Here, the median age was 49, and the tumor size at diagnosis was fairly big. It's 50 millimeters here, because it was, as you remember, it was 2.3 centimeters in the previous study. So this study included a little bit larger tumors. And all patients, again, received radiotherapy to the breast, and all patients continued to receive adjuvant systemic treatments as appropriate according to the tumor boards. And the follow-up is also 67 months, which is a little bit more than 5 years. And at the end of this 5 years, among these 7 patients, there were no recurrences and no deaths. So this was also concordant with the result, having a result concordant with the previous one. So what about the axilla? Because you may omit surgery in the breast, but what about omitting surgery in the axilla? Because when we include these patients, I mean, when you have exceptional responders, mostly these patients may have a clinical node negative disease at admission. So according to this study from the Netherlands, they show that if the patient had an zero disease in the beginning, at the end of the neoadjuvant systemic treatment duration, they found that, especially in HER2 positive and triple negative patients, of course, the likelihood of having complete response or no disease at all in axilla is more than 98%. So again, we are talking about a very early disease in axilla in this patient cohort. So if the patient has an N0 at admission, therefore maybe there is no role of doing sentinel lymph node in these patients as well. Another study from the United States, again, this is a very recent study, only included HER2 positive cancer patients. As you can see on this slide, not only node negatives at admission, also the node positives, which included only 66 patients hit, as you can see. If the patient had a breast PCR, then the likelihood of having a remained disease in axilla is 0%. So all patients had a node negative disease at the end of neoadjuvant systemic treatment. So again, this study also showed us that there would not be any role for sentinel lymph node biopsy in these patients if the patient's tumor had a good response to neoadjuvant systemic treatment in, again, those cancers with HER2 positivity and triple negative. So what about hormone positive tumors? Because we know that the response to hormone positive tumors are not so good. So, well, there is a response to neoadjuvant systemic treatment, could be endocrine treatments as well. So what about not doing surgery in these patients, but instead using an ablation method such as cryoablation? So this study is so far the largest study. It's a one-arm cohort prospective cohort, is a multicentric trial using cryoablation in those patients less than 1.5 centimeters. So they included those patients with not only all patients receive radiotherapy. As you can see, only 15% of those patients had the radiotherapy, and less than 1% had the chemotherapy. Also, again, not all patients had an endocrine treatment. As you can see, only 2/3 of those patients had an endocrine treatment. Therefore, it means that 1/3 of the patients did not receive endocrine treatment as well. So at the end of, again, nearly 5 years, this is just published 1.5 months ago. So you can see that only 7 patients out of 196 tumors, which just corresponds to less than 4% of recurrence in breast recurrence. So this can be comparable to the surgery itself with breast conserving surgery at the end of 5 years, which is just regarded as an excellent result. But please remember that in these cohort, they are elderly patients and with the tumors with good features. So again, when you look at the adverse events, they had only 2% of the patients had a severe adverse event. On this slide, you can see table that you can see 88% had a mild adverse event. That's also comparable to surgery, because surgery is not eventless, as you can see. It's an ablation is a trauma to the breast. So even when you do a conservative surgery, I can assume that 100% of those patients has a mild adverse event, like you have a wound in there. So 88% of a mild adverse event is acceptable in this regard. So again, when you look at the patient and the physician satisfactions, again, they have an excellent result, near to 100%. So again, when you look deep into in this study, those who only received endocrine treatment, because I said that 2/3 of that only had an endocrine treatment and 1/3 of them did not have endocrine treatment. If you only look in the endocrine treatment group, only 3% of those patients had a recurrence. Also, as I showed you, only 15% of the patients had the radiotherapy. That means 85% did not receive radiotherapy. All those 7 patients had a recurrence were from the group who did not receive radiotherapy. So those patients who received radiotherapy, there was no recurrence. So as a conclusion, in elderly patients or over 60 years of age, but for today, of course, maybe in future, we may just extend this age limit down to 40. So with low risk, which means that smaller than 1.5 centimeter tumor and 0 grade 1 or 2 and luminal tumors, we may apply cryotherapy, a cryoablation in these patients without making any surgery in these patients as well. So another small subset of patients from the United States, again, 32 patients who received adjuvant endocrine treatment, only 20% had an adjuvant radiotherapy. At the end of 2 years of follow-up, which is a little bit short, as you can see, there was no recurrence in breast recurrence. Only 1 patient had a recurrence, and that recurrence was in the axilla. So maybe we may not have surgery for the local regional treatment reasons, but what about when omitting the surgery and you're just get rid of the possibility of having a staging, actual staging of the tumor in the disease in this setting without applying surgery in these patients? So how we can tailor the adjuvant treatments without doing surgery? So today, why we do cancer surgery? Because we calculate the size of the tumor. We understand the number of the lymph node, involvement in these patients. So we make the TNM staging. So for the T size, which is the tumor size, is it really integral for treatment decisions? Because today, mostly we're not depending on the tumor size anymore, because according to the subtype of the tumor, either we use genomic profiling in hormone positives, or even in the HER2 positives and triple negative tumors, we're just looking at the node positivity, and regardless of the tumor size, we're deciding on whether to give chemotherapy or other systemic treatments such as anti-HER2 treatments. So we are less and less dependent on the T and N staging in these patients. Again, from looking from another angle for the pathology, so we of course, very keen on reading the pathology report on the T size and the N stage. But what about interabsorber variability? Because we know this is obvious, because when 2 pathologists sit together in different microscopes, they may size the tumor differently. So do we really know the actual tumor size in this case? Because we depend on the pathology, but is it really the truth? So agreement is low on the exact size of a tumor at given in the specimens. So today, the prognostic staging includes not only anatomic factors, now we just added to this tumor-specific factors, such as the tumor biology, because the new AJCC cancer staging includes the biology of the tumor, like the ER/PR status and the 21 gene recurrence score, to improve the discrimination of prognosis among tumor stages. And today, on the horizon, we know that liquid biopsy is coming, such as the circulating tumor cell or tumor DNA, cell-free DNA, and extracellular vesicles can be, quantified in the liquid biopsy and can give us an important message in order to understand the prognosis of the patient. So the important point here is detecting the minimal residual disease after the surgery, because when you do the surgery in the breast and axilla, normally what you see is there's no tumor behind. But is it really? I mean, when you look at you can't see the distant organs very accurately to understand if there's a micrometastasis or any circulating tumor cells just floating in the vascular system, and can go and just attach to distant organ and begin a distant metastasis. So detecting the minimal residual disease after surgery should be important in our future management of the breast cancer. Also, during the follow-up, because we depend on the imaging only and the physical examination, but by making interval sampling of the blood by the liquid biopsy, if you find the early recurrence, and by monitoring the blood, you can see the recurrence coming in earlier than the imaging can tell you. So today, we know that there are many studies showing that this in the pipeline and still going on in the research field, that the circulating tumor cells and circulating tumor DNA upfront that we do predict a worse outcome, not only in the hormone positive, but also the other subtypes of the tumor as well. Also, after the surgery, when you detect a CT, circulating tumor DNA, again, when you see this, you can understand if there is an appearance of the tumor cells after the surgery, after the adjuvant treatment. It also gives you a message that the tumor will recur eventually in time, so you may adjust your extended adjuvant treatments or preemptive treatments in these patients as well. Again, another study which is very interesting, that they just divided patients into two cohorts. In the first cohort, the patients, the adjuvant treatment is decided by the classical methods, by the tumor boards, depending on the tumor specimen pathology report. In the other cohort, they just gave the adjuvant treatment according to the liquid biopsy results. So at the end of the time period, they found that the outcome in both groups are the same by means of overall survival and progression-free survival. So again, the circulating tumor cells course predicts the overall and disease-specific survival after upfront surgery and adjuvant treatments as well. So as you can see, more and more studies, such as in success study, the use of liquid biopsy is becoming more important than understanding disease by only looking at the pathologist specimen. Again, in the late adjuvant period, the CHIRP study found that if there is in hormone-positive tumors, of course here, because there are many studies not only on hormone positives, also HER2-positive and triple negatives, they found that in the late adjuvant period, if there is a detection of the DNA in the circulating tumor DNA in the blood, in the liquid biopsy, it is related with the recurrence. So also after neoadjuvant systemic treatment, the circulating tumor cells and the circulating microRNA predicts the recurrence and survival. So in triple negative cancer, this is a very recent study. The early clearance of circulating tumor DNA is predictive and prognostic in triple negative breast cancer. So personalized DNA monitoring during the neoadjuvant chemotherapy, not only at the end of the neoadjuvant chemotherapy, may help to predict response and guiding the treatment. Also, this study is very interesting, and this is from the United States again, and they found that the circulating DNA analysis is superior to pathological assessment for predicting patient outcomes. As you can see on the slide, if the patient had a PCR and the circulating DNA is negative, the prognosis is superior, is excellent. So if there is non-PCR and is a circulating DNA positive, then as you can see, the prognosis is dismal, it's very bad. But in the end, when you do the surgery, there's no PCR in the surgical specimen, but the CT, the circulating tumor DNA, is negative. As you can see, the prognosis of this group, although there is a remaining tumor after the surgery proved by the surgical specimen, the prognosis is similar to those who had a PCR, an actual PCR, and the circulating tumor DNA. So this is a very important study showing us not the tumor pathology, but the circulating tumor DNA, which in fact, in turn, is the liquid biopsy, is much more important than having the biopsy specimen at the end of the surgery. So the contemporary prognostication and predictive classification may include the genomic profiling, identifying the tumor somatic gene mutations, and the circulating tumor cell or DNA or microRNA. So these are the futures, and that we may apply to our patients, not only the surgical treatment by having a surgical specimen and putting it under the pathology microscope, but also, or the measuring the tumor size or the node involvement. But these seems to be the most important, more important than having those actual pathological reports. So as a conclusion, omitting surgery seems to provide an acceptable local control in only HER2-positive and triple-negative cancer patients who had a complete response after neoadjuvant systemic treatment when determined by adequate measures, which is MRI or other imaging methods, plus vacuum-assisted biopsy. But remember that the size of the size of the sample in this study is very small, so we need to wait for the result of the larger cohorts. So overall, in disease-specific survival, so far excellent after 3 years in this patient in this study, which is from MD Anderson. And liquid biopsy seems to have the greatest potential to screen the disease under systemic treatment without necessitating liturgical confirmation. And phase 3 studies are needed to understand the non-inferiority of de-escalation in the contemporary and ongoing era of advanced systemic treatments. So, as a conclusion, at the end, if the pathological complete response is equal to surgical resection, I mean by neoadjuvant systemic treatment, of course, and if the liquid biopsy gives the same information as the pathological specimen assessment, then in future, there is a potential of no surgery. Thank you very much for your attention.
Thank you very much, Dr. Bahadir, for your exciting lecture. I'm sure there will be lots of discussions at the end of this session, so please stay with us. Now I call the next speaker, which is Dr. Imad Racha, Professor of Breast Pathology and Honorary Consultant in Pathology at Nottingham University, as well as in Hamad General Hospital in Qatar.
Assalamu alaikum. First of all, I would like to thank the organizing committee for this kind invitation, and I am very happy to be with you today. To be honest, I started discussing having a breast institute in Egypt in 2009, but I failed. I was not successful to convince anyone to have a breast institute or an institution like Bahia in Egypt in 2009 and 2010, but there was no enthusiasm about it. But I am very, very happy to see this initiative is going forward and very successful. And the second thing I would like to, because we are all attending this session, we need to have our own guideline. So the next step is our own guideline for Egyptian patient. We have different patient pathway, different adherence of the patient to treatment. We don't need to follow any CCN guideline or UK guideline or Australian guideline. We need to have our own breast guideline for pathology, for radiology, for surgery, for oncology, and for patient pathway, for screening. How can we manage screening in Egypt in view of the local circumstances in Egypt? How can we manage this based on the local situation, not just copying any of the guidelines from outside or copying some of the clinical trials, like what happened now in the Gulf countries, where they copy clinical trials. But the clinical trial is not the same patient, it's not the same population, it's not the same environment. Your patient is different. The biology is different, the economy is different. So hopefully next thing would be having a guideline for our own patient. My talk today is about B3 classification. B3 is one of the entities of categorization of breast lesion, mainly in the screening setting. So why do we need to categorize breast core biopsy? We need to have a common language between the different teams of the multidisciplinary team. So we need to have a better communication between the team, between pathologist, radiologist, pathologist and surgeon, and oncologist. Using a categorization like B coding will improve the communication between the team member. And so some of the entities have various names, difficult to know. Oncologists, radiologists are not supposed to know all the pathological entities. So, but if we can lump these entities together for single management, this will make it easy. Similar to BIRAD system. The BIRAD, I am a pathologist, I don't know what is the coarse calcification versus fine calcification, distortion, but I know BIRAD. If it is BIRAD 3, different from BIRAD 4, different from BIRAD 5. So it is very important to have something like a common language between us and use it to facilitate the communication and for better patient management. In routine practice, most of the cases we see in symptomatic, they are malignant, so B5 or malignant, but still some cases are benign, some cases are normal, and some cases are not sure. And these are not sure how to manage them, especially in an initiative like Bahia, where they started the early detection. So you may come across some of these cases, higher frequency, like between 5 to 7% will be B3 lesion. And something else, when you have a cancer, you have re-imaging and you may pick up abnormality. This abnormality can be B3. So you will face this situation either in the early detection or even in cancer patient. The B category is similar to BIRAD, 1 to 5. 1 is normal, so the patient can be, if it is radiologically BIRAD 2 or 3, the patient can be discharged without follow-up. B2 is benign, so if it is benign on imaging, benign on pathology, it discharges the patient, no need to follow up. unless there is a concern in radiology. If it is B5, this is a radical management based on in situ or invasive. B4, this is surgical intervention, no radiology, this is surgery. It has to be surgical excision, diagnostic excision, not therapeutic excision. It has to be surgical diagnostic excision. And when it is B3, how to manage it? So B3 is not benign, is not malignant. So B3 is a group, is a heterogeneous group of lesion. All of them are not malignant, are not benign. They are usually associated with a higher risk lesion. So a lesion which is frequently associated with DCIS, with a small focus of invasive carcinoma, and is difficult to manage, is not enough, but we don't know what is happening in surrounding tissue. And these lesions include what's called atypical ductal hyperplasia, which is a small DCS. Atypical ductal hyperplasia is not an entity, is not a wrong diagnosis and right diagnosis. It is a small part. It can, DCS will start one day at one cell, and then 2 cells, and then 3 cells, and then in 1 duct, and then 2 ducts, and so on. So ADH, when it is pure in excision specimen, it is early DCS. When we see it in a core biopsy, it means that we don't know. If you have more, it will be DCS. If we don't have more, it still remains as ADH. So it is not a wrong diagnosis. It is a small size of a lesion. If we have further tissue and more, we found more, we call it DCS. If we don't find more and it remains as a small focus of low-grade atypia, it's called the ADH. Lobular neoplasia, we know lobular neoplasia, LCIS, but it's not one entity. It includes the classic lobular neoplasia, which is B3, which we can manage as a risk lesion. But there is a pleomorphic LCIS, which is treated as DCIS. So it is not B3, it is B5. It is malignant. So pleomorphic LCIS is DCIS for management. There is a new entity, which is increasing, discovered now, is florid LCIS. And this is until now, we don't know, is not DCS, is not LCIS, so we call it B4. But it needs treatment, it needs intervention, maybe surgical intervention. Flat epithelial atypia is something, is a bit of early atypia. Pathologists have very low concordance of this, but we need to manage as atypia. And the other lesions which we know, papillary lesions, low-grade spindle cell lesion, and cellular fibroepithelial lesion. When we have something we don't know, is this fibroadenoma or phylloides tumor? If you leave this in the patient, if it is phylloides, it will continue to grow. So it will make surgery difficult later on. And we don't know in the background, it can be upgraded to borderline. So we need to have excision of this lesion. Why surgical excision of cellular fibroepithelial lesion? Because we need to assess the full features of the lesion. So cellular fibroepithelial lesion is one of the B3. Other rare lesion, we don't know what is this. We need to have a biopsy, like if we call low-grade vascular lesion. This could be angiosarcoma. And we have seen several cases of angiosarcoma coming as hemangioma in the breast. That's why any vascular lesion in the breast, except if it is vascular lipoma or I can't remember the name, any vascular lesion in the breast should be treated as B3 and should followed by surgical excision, not vacuum. Surgical excision, because the risk of missing low-grade angiosarcoma is high. Some other entities like pleomorphic adenoma, adenomyoepithelioma, microgranular adenosis, mucocell-like lesion, and other rare lesion, granular cell tumor. These lesions, we don't know how to manage them. We need to have excision. Excision can be vacuum-assisted excision or surgical excision based on the lesion. And this has to be passed to the clinical team. In the report, don't wait for MDT. If it is granular cell tumor, I would suggest excision. If it is vascular lesion, I would suggest this is vascular lesion, low grade, and the specimen is insufficient for a definite diagnosis, surgical diagnostic excision, or at least vacuum assisted if it is not possible surgery. So we need to have more tissue to exclude the possibility of low grade angiosarcoma. If we look at B3, the positive predictive value is variable between 40% to 1 or 2%, and this is mainly based on atypia. Do you have atypia or no atypia? And the positive predictive value means that you can have DCIS or you can have invasive carcinoma. The treatment of B3 is a bit challenging. So, because what is the nature of the lesion? Is it atypia, no atypia? Is it papillary lesion with atypia or ADH? So no papillary lesion, no other lesion. So is it one single lesion or combination? Is it EDH and LCS or LCS only or EDH only? So you have to consider it is not one single entity, it's a heterogeneous group. But at the end of the day, we need to how to manage them. So we have two lines of treatment. When we call it B3, either vacuum-assisted excision or surgical excision. If the lesion is small, for example, less than 2 centimeters, radiologist can excise the lesion, it will be easy. If the pathologist doesn't need a surgical intact specimen, we can go for vacuum-assisted. But if we need intact specimen, like in case of cellular fibroepithelial lesion or papillary lesion with atipia, we need to go for surgical excision. So the recommended now is surgical excision is recommended in case of papilloma with atipia, because it's very difficult for a pathologist to decide what is this DCS or ADH or what is the extent of atipia if it is vacuum. So we need to have surgical excision. Cellular fibroepithelial lesion is bendy cell lesion, and the other lesion, rare lesion like microglandular adenosis, surgical excision. Situation where we have vacuum assisted excision, when it is ADH only, so vacuum assisted will be fine. When it is papilloma without atipia, when it is radial scar without atipia, excision, vacuum assisted excision is fine. If it is large radial scar or large papilloma, they have to go for surgical excision. Just for pathologist, just a few pictures I will go quickly. This is papilloma, benign. So, but benign, should we leave it or not? Because we don't know what is happening in the background, we advise for vacuum-assisted excision, just to excise, to look at the specimen. So, if the patient doesn't want surgery and the lesion is small and pure, you can leave the patient. In our situation, not the guidelines is that vacuum-assisted excision, but based on patient preference. So it says you can tell the patient this is benign lesion, no atipia. So it's up to you if it is small. If it is large, you need to excise just to know what is happening in the background. Because sometimes you have a small focus of atipia like this one. It's a bit small focus of atipia at the bottom part of the specimen. So is this very small like ADH type or extensive? Sometimes the whole lesion is a bit worrying for us, but it's not enough to call it DCS. So in papillary lesion, we examine myoepithelial cells, we examine the epithelial cells, and we do immunohistochemistry. Most of the cases of papillary lesion, we perform immunohistochemistry, but sometimes we cannot confirm is it DCS. So in this case, we have to have surgical excision. And the management is based on the papillary lesion, based on atipia. Do you have atipia? Don't you have atipia? And then after vacuum-assisted excision, is it pure? So that's okay. Patient can be discharged. Is it associated with atipia? Atipia is ADH or DCS, and then the management will be different. And we have several guidelines published based on this. The second lesion, what's called the complex sclerosing lesion, radial scar. Both are the same entity, but radial scar is small, complex sclerosing lesion is large. So, and it is worrying because you can have DCS associated with it, you can have ADH, you can have other lesion. Sometimes even for pathologists, it's difficult to know, is this really a complex sclerosing lesion or complex sclerosing papillary lesion or adenomyoepithelioma or low-grade adenosquamous carcinoma. Sometimes you have infiltrative gland, you are not sure is this invasive or not. So clinician should understand that pathologist is not black and white. It's difficult, is you have to, there are some areas, it's very difficult to make accurate diagnosis on a small specimen, a small tissue, limited tissue material. So for these lesions, we need to have more tissue, examine the periphery to make sure that we don't have DCS, we don't have a focus of early invasive carcinoma, and some of the radial scars show what's called the adenosquamous proliferation. And this adenosquamous proliferation is part of low-grade adenosquamous carcinoma, which is triple negative carcinoma, but low-grade. So when we see adenosquamous proliferation, is this part of radial scar or is this part of carcinoma? How do you know? You have to examine the whole tissue. Flat epithelial atipia. I will ask a clinician, our surgeon colleague and oncologist, is there any difference between those 4 slides, 4 images? This is a pathologist's job. So it's not easy. You will find the first one, which you call the CCC, the first one on the left, this is called the columnar cell change, benign. But you move to the next one, is flat epithelial atipia, B3. Down, the 2 down are flat epithelial atipia. So the difference is very subtle. And the pathologist can, based on the interpretation, when we call the word atipia, we assess 8 features. So look at the cell, we assess 8 features within the cell. and then combine them together and make a final score and decide is this atipia or not. So it's not black and white. It is something complex and subjective. Flat epithelial atipia, when we see this is columnar cell change, this is flat epithelial, likely flat epithelial atipia, but we have to go to high power and then we look. So the features is like loss of polarity. What do you mean by loss of polarity? Very subtle changes, nuclear changes. So, and sometimes even in simple system, fibrocystic change, you see these changes. So we don't need to over-treat the patient, we don't need to miss. Why do we need to care about flat epithelial atipia? Because the entity which is called the micropapillary DCS can present as this one. And the micropapillary DCS can be extensive. But based on the sampling, you may get area where you don't have architecture complexity. You have only the base of DCS, base of the duct. So you get this one. But if you sample more, you will start to see architecture complexity. So this is one of the normal duct. But remember, you can look at the upper one. There's a bit now complexity of architecture. So the same, what's called the flat epithelial atipia, if you cut deep or take more tissue, you may get some architecture distortion like this or atipia. This will be called as ADH. You have more than 2 millimeter only, you call it DCS. Lower end of the spectrum of the slide is slightly higher grade nuclei. If you look, can you differentiate between above and below? This is DCS because it's high grade. The one above is ADH. So this is a difference, a very subtle difference. But still, that's why we need more tissue sometimes. We need to make sure that what is the lesion. So even in flat epithelial atipia, you accept some architecture like this tufting, but still not well-developed DCS. It's still tufting. When we have something like this, like these fingers, this polarized, this is part of micropapillary DCS. So what is the difference between this one and the previous one? There is nothing except those two fingers coming out of the structure. So this is micropapillary DCS. The other one, it was called flat epithelial atipia. This is the reason we ask for more tissue. And when we see something like this is easy for pathologists. This is ADH, and as I mentioned, more than 2 millimeter, it is DCS. And grade is very important because if it is intermediate grade, it is DCS. It's not ADH, it's not FEA. Flat epithelial atipia and ADH are low grade. If you call it intermediate grade or high grade, is DCS. But intermediate is a bit scary because what do you mean by intermediate? You will have 50% concordance among pathologists between low grade and the intermediate grade. So in this case, more tissue and the consultation and the more lipids and the more extra work will be needed. Is this atipia or not atipia? I'll give you an example. Is there any difference between those two? Our surgeon and radiologist and oncologist. If this is your specimen, will you differentiate between these? And this is the pathologist's job. So don't see that pathologists, I mean, they have high level of discordance. This is sometimes the lesions are very similar, like a low-grade spindle cell lesion, but we need to rely on immuno. So we just do some markers. The first one is colonal, so it is atipia. The second one is heterogeneous, so it is hyperplastic. But we not one immuno, 2 immunos, or 3 immunos or more. And then we decide this is colonal, so this is atipia. If this lesion is large, we call it DCS. If hyperplasia is large, it's still hyperplasia. So sometimes we struggle, and this is a borderline case. We are very good when it is invasive carcinoma straightforward. We are very good when it is normal. We are very good when it's fibroadenoma. But we have low concordance when it is in between, when it is at the gray zone. So the second one is lobular neoplasia. Don't worry about atypical lobular hyperplasia versus LCIS. As long as it is classic, it is classic. The problem is we lump them together into lobular neoplasia. Why? Because there is no point of separating them. The only thing is between radiologist and the pathologist. If we call it atypical lobular hyperplasia and the radiologist see some imaging abnormality, is not representative. So it is incidental finding, is not the lesion. But if you have well-developed LCIS, even classic, it means that it can make either calcification or mass lesion, or it can produce imaging abnormality. So it is mainly for correlation between pathology and radiology. But the management is the same. And sometimes you have ducts like this. This is columnar cell change and the lobular LCIS. So you can have 2 lesions together in one specimen. And this is what's called, is this ALH or LCIS? I don't care. But any lobular neoplasia. And then ask if you can see likely early atypical lobular hyperplasia, so look for the imaging abnormality. You may not have hit it during the core biopsy report. Is this LCIS or DCS? Or this is pleomorphic LCIS. So it's not different from the previous one. So it's not different. I mean, you know, it's a bit just the, so what we call it, we look at this is high grade. The nuclei cells are a bit large and variable in size and shape, so we call it pleomorphic LCS. But this one is aggressive, can be HER2 positive, can be ER negative, can be a high frequency of association with invasive carcinoma. The one scary is when we have low grade spindle cell lesion. We don't know what is this. There are several lines of several causes for differential diagnosis for low grade spindle cell lesion. Yes. So we don't know what is this. Is this scar tissue? Is this fibromatosis? Is this low grade fibromatosis like metaplastic carcinoma? So we need to have immuno. In this situation, immunohistochemistry must be done to differentiate between carcinoma. So the same lesion, same morphology, same everything, but immuno can differentiate between carcinoma, between fibromatosis, and the other lesion. So this is the final slide. This is just a rare lesion. When we see what's called adenomyobacterioma, go for surgical excision. The other one is microglandular adenosis, surgical excision. Vascular lesion, surgical excision. Pleomorphic adenoma, surgical excision. Because pleomorphic adenoma can be mistaken for carcinoma, can have something else. Thank you very much.
Thank you, Professor Dr. Ahmed. Now I have the pleasure and the honor to participate in this unique conference year after year with more and more success so ever scientific data. Congratulate the team and my dearest friend, Dr. Amani Hilal. This is a magnificent social, scientific, NGO. أنا مش عارفة أقول إيه في الحقيقة. Thank you for your effort and your team. Wishing more and more success. Now I have the pleasure and the honor to introduce a very important era in medicine, especially in oncology related to AI or artificial intelligence in breast. Honored to introduce Dr. Iman, Dr. Tamer, as well as Dr. Ahmed, while addressing this important topic. The floor is yours, Doctor.
Good afternoon, all. I am glad to have you all in our annual conference this year. Today I will give a short notice or short talk about the AI era in view of Bahia's experience. The artificial intelligence actually quickly progressed from the preliminary studies to different clinical applications. The continuous advancement of AI in the field of breast imaging were intended to enhance the workflow in breast imaging units, upgrade the diagnostic performance of breast imaging radiologists, decrease the number of false positive and false negative results, and enrich the impact of breast imaging radiologists on patient care. The AI-based solutions in breast imaging have already been studied and adopted, where several successful AI technologies have been introduced in the 2D mammography, mainly in the lesion detection rather than interpretation. But unfortunately, Middle East and Egypt have been running back in this race. So in breast cancer screening and mammogram, the AI improved the breast cancer detection, decreased the number of false positive and false negative results, reduced the false alarms, prevented the unnecessary biopsies, and identified early breast cancer. Actually, several well-established AI solutions were applied, like Unit, Delaney, Google Health, Maya Reader, which help to determine whether the AI system can recognize all forms of breast cancer, produce the accurate results for women of all ages, body types, and ethnic backgrounds, and reliably reduce rates of false negative or false positive versus standard readings by radiologists only. Here comes our collaboration with the AIC, the Applied Innovation Center, to develop an Egyptian AI solution with the Middle East Egyptian dataset of patients, resulting in the AIC Bahia Breast Cancer Early Detection Assistance System. And also we collaborated with the Linitic LLC in different areas, which we tested the MemoSuggest AI application for breast cancer screening and diagnosis, and we developed a synthetically generated contrast-enhanced spectral mammography imaging technique. The contrast-enhanced provides anatomic and functional imaging of breast tissue by combining standard 2D digital mammography with IV injection of an iodine-based contrast agent. Several studies have shown that contrast has a diagnostic accuracy superior to that of standard 2D digital mammography. Contrast-enhanced mammogram over the years has proved as an efficient tool for screening breast cancer, local staging, evaluation of intermediate breast cancer risk, dense breast, and breast asymmetries. So we aim to do the contrast-enhanced mammogram image without the need of contrast material injection using AI solutions, synthetically generated contrast-enhanced spectral mammography images. This helped to increasing in screening to improve the breast cancer visualization, use of contrast-enhanced mammogram without the obstacles of contrast administration or depending on kidney functions, and economic aspect, saving money of contrast media injection. Here are two different pictures of two different cases. One of them is the virtual contrast-enhanced mammogram, and the other is the real contrast. I don't think there is a significant difference between two images that we can clarify. Actually, this one is the real contrast-enhanced mammogram, and this one is the real one. I'd like finally to thank all the radiology team which is behind this big project, mainly the project manager, Dr. Amr Farouk, which unfortunately can't attend this year, the project consultants, Assistant Professor Dr. Sahar Mansour and Dr. Muhammad Goma, the project coordinator Asma Ale, and I have a big dear doctors and colleagues in the annotation team and also in the data collection team. Okay, let me introduce our guest speakers, Dr. Tamer Sharnoubi, Principal R and Dutch Leader, Applied Innovation Center, and Professor Dr. Ahmed Ihab, Department of Biomedical Engineering and Systems, Cairo University, Chief of Operating Officer, Astute Imaging LLC. Thank you.
Hello, everybody. My name is Tamer El-Sharnoubi. I am the Principal R&D Leader in AIC Center. AIC is part of Ministry of Information and Communication. We have been collaborating with the Bahia Foundation for about 15 months till now. We created an AI-based system. It's production level, and I'm going to talk about what it means to be in production level. As you have seen from Dr. Iman's presentation, the whole team, like more than 30 people, have been working on that. On the other side, that's my team, Minna, Mina, Mariam, Maram, Lina, Muhammad, Adham, and Ahmed. So let's go. Basically, we actually feed the mammogram and the patient information into the AI, and it actually detects the masses, calcifications, asymmetry. And for each one of them, it detects the BI-RAD level. And finally, it gives this confidence score about the confidence of the system of this solution, whether it depends on the age, the breast density, whether there is a lymph node, mass, contour, whatever. So, and we have the system actually live in that's our booth outside, and it shows more than 60,000 patients So we actually brought only a few hundred because I don't have hard disk big enough for that. Okay, what it means actually to be AI engine in production. First, the data gathering. The data gathering, we gathered more than 60,000 patients. It's much better now. We have more than 60,000 patients, and the Bahia team actually annotated those 60,000 patients. And I'm going to show you the annotation afterward. After that, we have trained the AI engine, which is about like 15 different models in order to detect the masses, asymmetries, and the calcification. Finally, there is the deployment factor, which is has to serve multiple hospitals, multiple doctors per hospital. So it has to scale regardless of the size of the hospital and the number of patients. So that's part of the engineering part. The last thing which I'm going to talk about is feedback. That means that the AI engine is running, but the doctors have to give feedback about what's going on. So here are the 60,000 that we got, and it has to mimic the real live distribution of in Egypt. This is an example of the annotation. So the doctors in Bahia Foundation, they marked every single mass, calcification, and asymmetry. And they detected the ACRB, and also they marked the pectoral muscle in order to remove them. So the first part of any AI engine is that we pre-process the data, we convert it to a format that can be readable by the engine. The next part is to separate remove the pectoral muscle. As you can see, we removed it from here. And this is also an AI model. The next part is to detect the mass, okay? So we detect all masses regardless of the BI-RAD or anything. Next step is to determine the BI-RAD model. So the system actually detects everything and determines the BI-RAD model. And the doctors can choose to see everything. They can see the only BI-RAD 4 and 5, or can see 2 and 3, or nothing. The next step is to segment, to actually detect the exact place of the mass, is the contour of the masses itself, or the calcification, or okay. The same image actually is gonna be entered to another model that determines the breast density, because as you all know, the higher the density is more susceptible to cancer. And then we actually detect part of the masses on the lymph node. The reason is that we combine all those results in order to determine the confidence factor. So if there is a mass on the pectoral muscle, if the age is like 40, 50, 50, 60 or so, it depends. All that affects the confidence calculations. Then we combine all the results. This is just one pass of the model. Here is just an overview of the models themselves. So we have a different model for masses, for calcification, for asymmetry, for breast density, for lymph node. And this is one of the clear differences between production level and research. In research, usually researchers try to get just one single model in order to detect everything, which is infeasible. Infeasible in training, infeasible in calculation, evaluation, and everything. So we have multiple models. So actually, each one of them is actually 3 different models, and they are all communicating with themselves. The whole process depends, of course, on the hardware. The hardware that we have outside is, it takes 10 seconds in order to read all that. Here is the one example of the output. Here it detects the masses, okay, the asymmetry, another asymmetries, and then masses, and here the calcification. We updated that model. Actually, you can pinpoint the exact calcification point, which is Newton. Okay. One of the things actually that we did this example or this AI model is that is for Egyptian women because it differs because of genetics, environment, and hormonal everything. So that's why we needed to do that. There are other companies that actually started earlier than us, and they have been updating the models. Why do you need to update the model? The best case scenario, the accuracy of the model is going to stay the same. Okay, but that's not true. What happens truly is that the model accuracy decreases over the time. So in order to avoid that, we need to constant influx of data. So we created a feedback loop so that the doctors who are actually diagnosing the patient can update the model, can say, okay, this is actually a mass, but the BIRATS is wrong, or this is not a mass, the calcification is the yes, wrong. So it depends. So they can keep on feedback, giving feedback to the system. And we do a retraining every 3 months on the new data. So because as doctors, okay, you gain experience with more patients, continuous learning. Same for the AI engine. It needs all that. Thank you, and please visit us at the booth. You can, if you have your DICOM files, you can the mammograms, you can actually feed it to the system, and we have ours too. Thanks a lot, everybody.
شكرا. Assalamu alaikum. First of all, I would like to thank you for inviting me and thank Bahia for this honor and opportunity. Special thanks to Dr. Rasha Kamal and Dr. Iman for inviting me to be here today. So my name is Ahmed Ihab. I'm a faculty member at the Faculty of Engineering, Professor of Bioengineering, and same time I'm currently the Chief Operating Officer for Astute Imaging. But let me give you a background. Astute Imaging is an Egyptian company that started 2018, but the effort behind it for R&D started since 2015, just in order to achieve something or a solution for AI. So we mainly focused on AI in medical imaging. We developed several solutions. Part of it was for breast, and successfully we have been acquired by a US-based company called Astute Imaging. What's the journey for Delenitech? Delenitech started at 2018. It started by working with one of the biggest companies in the world, with US. We developed solution in AI for breast, and then we moved into partnership with NVIDIA. We have been towards working with them, and then we got our first US patent in 2020. We published a lot of publication. We established a lot of research in different areas. We deployed different solutions in different continents, including Saudi Arabia and US. We have been into Microsoft program, and we have been honored to have a partnership with Bahia in 2 different areas. that I will talk about. And currently, as of today, we have one of our solutions in Harvard University, and then until we acquire 2022. Right now, as of today, astute imaging is mainly working in aorta, not in breast. We have just one project in breast, which is the contrast generation. And this is, we feel, we are unique. The research group that's working with us, our publications now is being highly cited. Back, the Lenitech was aiming to have all-in-one breast solution. So from the start, before even the lady comes, she enters, she has been asked several questions and to determine the risk of breast cancer using the Gale models that have been developed by NIH. But our goal was to develop the Egyptian version, as my colleague just said. We need the Egyptian version of everything, or to adapt the AI model for Egypt. So that was our dream, to have risk assessment together with a mammo AI screening like what have been described, along with elastography, and that's what we got our US patent. We developed a patent where you can use your ultrasound machine, any machine, to develop elastography. That was important at that time before AI take it, and then generate a structure report. So again, as a physician, you go into our website, you have the data already uploaded, AI work, then you have your list is prioritized, you have been alarmed of suspicious cases, then you can look at the AI will highlight to you, color-coded the benign and malignant with their mass, with their calcification, and will give you an opportunity to adjust the PIRAD for that, and the opportunity to have a structure report. And also, even before a lady come, you can just phone call or web browser, you can enter, she can answer some question, and you can know the risk factors. This is our US patent for elastography, and this is just regular ultrasound machine without, and that's the results we generated. There are two projects. The first one was, we had already a workstation for breast imaging. It's a US trademark called MammoSuggest, and we deployed it in Bahia, and we integrated it into the workflow in Bahia Foundation that was initiated by Dr. Rasha and collaboration with Dr. Muhammad Goma, Dr. Amr, and so that was the evaluation for it. And we got very important feedback about our technology, the sensitivity, specificity. That was very important. And that's, in developing AI, working in research is something, and developing a solution is a different thing. So I have been working in different companies, taking solution from bench to bed. So it's totally different experience. So having the evaluation from your sober user, which is sober user in Egypt, Bahia, that was very important. We got evaluation, we got feedback, and then same time, we know how to integrate with the workflow. The second project, which I think is state of the art right now, and we have different publication on it, is how to generate. Let me take one step back. So Dr. Iman, thank you for the introduction about contrast mammo, because that was, so contrast mammo is mammo plus contrast agent. The purpose is to enhance the visual localization of abnormality or the visibility. Plus, it could be an alternative for MRI, which is low cost, which has some more flexibility. Limitation is more exposure to radiation. Limitation could be higher cost and additional exposure time. Our vision, we used AI, recent deep learning model and conventional model to generate synthetic images almost, as you can see, this is a regular mammography, full field mammography. The image is in the middle is conventional contrast enhanced with contrast there, and the last image is synthetic contrast image without enhancing, without anything, just from the conventional mammography. We did that over many samples. We did that over different abnormalities, and we have generated those, and blindly we gave those images to different radiologists who assessed how similar are images, and those results have been put in different publication. One of them is in the ACR, another journal paper is in the Biomedical Signal Processing Conference, and this is the recent one that will be submitted to a very decent journal in the field of using deep learning technologies. Just let me take back our team, and it's just a research team. So I would like to thank the Bahia team, including Dr. Rasha Kamal, including Dr. Muhammad Goma, including Dr. Amr. They are part of the team. They are part of that work. I would like to thank our engineering team, which is Manar, she's a PhD student, and she just will be defending her PhD, and she's one of the engineering, and my colleague, Dr. Muhammad Rojdi. We would like to acknowledge people who helped that research, including Dr. Sahar Mansour, Dr. Aula, Dr. Mai, Dr. Enji Nihal. And finally, I would like to thank you all, and thank Bahia, and thank everyone. Thank you.
Thank you for the AI teams in Bahia. And now with the last presentation in this session, Professor Dr. Ahmed Amin and the Regional Nodal Irradiation in Breast Cancer.
Good afternoon, everybody. Good afternoon, chairpersons. As usual, it's a great pleasure to be presenting at the Bahia International Conference. Since this is the last presentation in the session, so I will try to make this quick, not to delay you for your lunch break. So today I'm going to address the update in the regional nodal irradiation in breast cancer. So when we have a decision to irradiate any breast cancer patient, it seems to be easy to take decision for nodal irradiation, but in the fact, nodal irradiation, it's a bit complicated, and there's a lot of answers that are not still addressed so far. We all are familiar with the station of the breast, the axillary levels, the supraclav, the internal mammary, and the intramammary levels. In general, we have to know that the surgeon, they have access to level 1 and 2. It's easy to be detected, but for the level 3, radiotherapy is the main treatment for such level. In general, what are our indication for lymphatic irradiation after surgery? We have to differentiate between the patient who's going to go for upfront surgery or the patient who's going to have a new adjuvant treatment. After upfront surgery, we have to irradiate the patient who are having a positive lymph node, for sure, the patient with T4 and 3 disease, and of course with the patient who are having positive internal mammary or supraclavicular nodes. For the patient who are having a new adjuvant chemotherapy, we should mainly evaluate the patient pre-chemotherapy. This is the main classification or staging. And then we have to irradiate the patient with T3, T4 disease, the patient with positive nodes, and the patient with internal mammary or supraclavicular nodes. For the patient who achieve CR after, who were initially positive and achieve CR after chemotherapy, they are a special category who are going to be addressed. And the patient who were clinically negative before chemotherapy, this patient, there's a lot of controversy about them. Some people, they think that if they were not properly assessed, we have to irradiate them for the benefit of doubt. Some other people think that no, they were clinically and radiologically free, so no need for radiotherapy. So this is one of the dilemma in our practice. But our trend, our trend is going to not to offer radiotherapy for much patient as we can to avoid the toxicities. So in general, patients who are having mastectomy and they're having N1 disease, 1 or 2, 3 lymph nodes. We had earlier data from the Danish trial in 2004 that those patients, they might not benefit from radiotherapy to the supraclav or at all. But recently we have in 2017 more valuable data from the breast cancer trialist group that those patients they benefit from radiotherapy, not in terms of overall survival, but as a disease-free survival benefit. But there's some criticism that this trial did not include some patients with negative nodes, included some patients just because they had grade 3 or lymphovascular invasion or ER negative. That's why the data of these results, they are, for us, sometimes they're not that valuable and need more and more evaluation. That's why there is the MA39 trial, which is an ongoing trial to address this. It's still ongoing, and hopefully we're going to get this answer soon, hopefully. Another important question is the axillary nodal irradiation after sentinel lymph node biopsy. Of course, we had the earlier trial from the Z11 trial that revealed that radiotherapy is equivalent to axillary irradiation, equivalent to axillary lymph node dissection. Of course, this trial had some limitation in terms of low accrual, and some patients already have micrometastasis, which is not considered as a positive node. Then we had the AMARUS trial. Of course, you're familiar with the AMARUS. The AMARUS were more betterly designed trial, and they gave us more evidence that axillary irradiation can replace the radiotherapy in the patient with positive axillary sentinel lymph nodes. And actually, the AMARUS also gave us very encouraging results in terms of toxicity. The patient who had lymphedema in the radiotherapy arm were significantly different from the patient who had the surgery. That's why even our MDTs were always favoring radiotherapy as a whole axillary radiotherapy compared to surgery whenever the patient is candidate for such treatment. Of course, now we are having even more and more advanced trial ongoing. These trials, they are even evaluating the patient who had clinically negative, clinically N1 trial in the beginning. In the AMARUS and the Z11, they selected patients who were clinically negative, but now we're even addressing the patients who are clinically having N1 nodes, so that we might consider omitting radiotherapy for axillary radiotherapy versus dissection. And actually the guidelines followed these trials, the guidelines, the ASCO guidelines, the UK guidelines, they are all of them, they're recommending radiotherapy for this category of patients. Is it possible to omit regional irradiation for patients achieving pathological CR? This is a very interesting area and a very interesting subject for research. We're having two important trials, the Alliance trial and the B51 trial. We are lucky enough to have the results of the B51 trial released. So I'm gonna go through the B51 trial. The design of the B51 trial is to recruit the patient from T1 to T3 with positive nodes, and this positive nodes is confirmed by fine needle or true cut biopsy. So we're even sure that those patients, they has positive axillary nodes. Then those patients, they have neoadjuvant chemotherapy. For those who achieved pathological CR, they are randomized whether to receive radiotherapy for this initially positive regional lymph nodes or to omit lymph nodes at all. So it was an interesting trial, and more interestingly that those patients, they were exactly similar. You can see the lines in terms of recurrence-free survival, in terms of distant recurrence-free interval, and disease-free survival, and overall survival. So from this very valuable data, radiotherapy after its role after chemotherapy is now much limited. So for the patient who are achieving pathological CR after chemotherapy, you might consider omitting radiotherapy safely. Which node the level to be treated? This is also something important because some physicians, they treat the whole axilla for each case, and this is actually not the proper practice. When we're offering radiotherapy to the whole axilla, we're raising the risk of the lymphedema. So we have to know that with any intervention or treatment to the axilla, whenever the treatments are more aggressive, we're getting more lymphedema. So it's better to, so after axillary dissection, treating the whole axilla with radiotherapy, this is not recommended at all. We have to understand the level of the axilla and offering radiotherapy to the level which need to be irradiated. So in general, we have the medial group. Medial group, it's almost irradiated for any patient who is a candidate for axillary radiotherapy. The medial and lateral group should, or we can sometimes addressing it as whole axilla for the patient with positive sentinel lymph node or negative sentinel lymph node after neoadjuvant chemotherapy, inadequate axillary dissection, and of course R1 and R2 axillary dissection. Some physicians, but there is no consensus that they consider whole axillary radiotherapy for the patient with heavy axillary nodal deposits or with extracapsular extension. And of course, internal mammary lymph node should be, whenever positive, should be one of our group target. Should include the internal mammary nodes for all patients receiving regional irradiation. This is also very interesting area. The trials are a bit contradicting, but I will introduce one of the very recent trial. It was released last year, the beginning of 2023. They randomized the patient, the left-sided patient, they didn't offer radiotherapy for the internal mammary, and for the right-sided patient, they offer internal mammary since there is no toxicity, and the results were all of the results were significant towards the internal mammary lymph node. By the way, those patients had early breast cancer and had either mastectomy or conservative. So according to this data, they were encouraging to include the internal mammary for all patients in case it's not toxic for our patient, and whenever the proper technology is available in order not to insult the heart. It's another question, what is the optimal radiation dose for the regional nodal irradiation? We have multiple accepted doses, but with the most advanced or the most recent protocol, the fast forward protocol, we should like minimize or decrease the dose for axilla. If we're offering the breast 26 grays, we should consider only 25 grays to the axilla. How to treat residual nodes after axillary surgery? If we're having, after surgery, we're having a residual supraclavicular node or we're having a residual internal mammary, of course it won't be dissected. We should consider boosting this node. This data was published in the ASCO conference, and they recommended that for 40 patients who were presented who received radiotherapy boost, only 3 of them experienced recurrence. So if the patient had supraclav and received chemotherapy, and even if this supraclav disappeared, always consider boost to the positive internal MAM or the positive supraclav. For the patient who are having, sorry for something wrong with the font maybe. For the patient who are having N-mic or isolated nodes, for this patient, they should be considered as a negative axillary patient and no need to treat this patient, because sometimes we're having some debates about those patients. Should we include the regional nodes when we're prescribing adjuvant radiotherapy after excision of local recurrence? Unfortunately, this question was not answered in any of the literature, and we're keeping such patients for discussion in our MDTs. Another question, is it possible to re-irradiate the regional lymphatics after excision of the isolated regional recurrence? We're talking about the patient who already had axillary irradiation and they had a local recurrence which was excised. Should we irradiate or not? This is also an individual and case-by-case decision, and in all of the MDTs in Egypt and outside Egypt, it's always an area for debate and discussion. Can we extend the supraclavicular feed to include cervical node for patients with positive ipsilateral cervical node? We're having some of these patients, Dr. Amira always bring me such patients without any metastasis, but just maybe a lower cervical node. Should we include them or not? And again, this area was not addressed in the literature and need further research. So my take-home message is that breast cancer regional nodal irradiation is an interesting area for research, where a lot of debate need more clarification. Omitting regional nodal irradiation or reducing its volume is preferred to minimize risk of radiation toxicity. Decision for nodal irradiation volume should be individualized for each patient. Radiation doses might be escalated for selected patient with residual involved nodes. And thank you very much.
Thank you, Professor Ahmed Amin, for your nice presentation. Now, because we are exceeding our time, so we will allow just for a couple of questions. If anybody has any question for Dr.
دكتورة هبة, just a questions. احنا طبعا في السيشن النهارده اتكلمنا على حاجتين مهمين قوي, اللي هو non surgical management for breast cancer, والحاجة التانية كمان ان احنا مش هندي راديو ثيرابي لو ادينا كيموثيرابي. وحضرتك كنت بتتكلمي عن نيو ادجفنت والادجفنت, هل الفكرة دي ما تديناش ان احنا نسكاليت بقى في الكيموثيرابي بتاعنا والاميونوثيرابي والتارجت ثيرابي؟ لان I think ان هيبقى the only treatment كده مفيش قدامنا الا الكيموثيرابي.
شكرا يا دكتورة مها يعني على الابروتش، بس بالعكس تماما العالم كله بيتجه الى ليس ثيرابي. ايوه العالم كله بيتجه الى ليس ثيرابي، فانا يعني في الكيموثيرابي دائما يعني عندي الابروتش ليس كيمو، ويا ريت اندوكراينال we can escalate according to some gene profile او بايو ماركر. واللي حل الموضوع ده ومشي معايا ويعني انا شويه معجبه بيه اللي هو الايرلي ريسبونس ده الدايناميك. هي طبعا عينها هتاخد بايوبسي تاني، على فكره احنا في معهد الاورام في التجمع عندنا ongoing trial كده بعد 3 أسابيع بياخدوا بايوبسي تاني. وفي قسم الراديو ثيرابي تبع الاستاذ الدكتور مدحت السباعي بيدوا بري اوبراتيف، دي صيحه جديده جدا هنقولها في مؤتمر المعهد ان شاء الله، بري اوبراتيف راديو ثيرابي وياخد بايوبسي. يعني فاهمه قصدي حضرتك؟ فالدايناميك ريسبونس لا طبعا اللي انا جايباه ده كله اسمه بريست سنه 24 واسمه العالم كله بيتكلم على you can de-escalate really، بس مش من مخك، من حاجه او يعني سوري مش من مخنا according to stratification. وعلشان الاستراتيفيكيشن ده يبقى كويس يا ريت يبقى ما نستناش عليه. اللي مش هيلو في proliferation يوطى بالجريد وبالكي اي وبشكل ده. في حاجه كمان بس ما كانش في وقت اسمها بيب سكيل في الاندوكراينال ريسبونس، بيشوفوا الاي ار والبي ار قلت ولا لا. يعني لو انا باديه 8 من 8 وبقيت 3 على 8 انا كده رايحه في كيموثيرابي. العكس صحيح، لو انا بديه 3 على 8 وابتدت بعد هذا الاكسبوجر اوف اندوكراينال تريتمنت بقت 8 على 8 يبقى برافو دونت تاتش هير ويز كيموثيرابي. فده رايي بالنسبه للحاجه اللي انا فاهماها. بالنسبه للقسم للراديو ثيرابي طبعا في كلام كتير الاستاذ الدكتور احمد امين يعني فعلا كل يوم في ديسكشن، هل ندي سوبرا كلاف، هل ندي اكزيلري بعد ما اختفت. ودايما دكتور شريف نجيب عنده محاضره مهمه جدا ان يعني اختفت لكن هي كانت الاصل موجوده ده في الراديو ثيرابي. الدكتور التركي طبعا هو فجر قنبله، يعني دي المفروض لو هو هنا في مصر كانوا الجراحين هيقوموا يضربوه دلوقتي. هو ولا عايز يعمل سنتينل ولا عايز يعمل كده، ده ايفن حتى البيوبسي عملها سونار جايدد فاكيوم اسيستد. يعني معلش ذيس از جوك طبعا، يعني هو سحب خلاص الجراح مش هي كده. فدي لسه بدري قوي قوي. الحاجه الوحيده اللي احب اقولها ان في ايطاليا دلوقتي في روم كانسر جروب فعلا ما بيعملوش جراحه للناس اللي دخلوا باثولوجيكال سي ار، ويدوا لهم لوكال راديو ثيرابي بوست على المكان وياخدوا 9 بايوبسي اول ثرو، لو واحده ولا فيهم حاجه نيفر سيرش. فالدي اسكاليشن في الغالب جاي يعني في
Thank you, Professor Heba. I don't know if Dr. Dr. Bahadir is still with us online or no, but really his presentation was shocking to some of the colleagues here, special surgeons. Now, I would like just to comment on that, if he's not online with us, that there are many non-surgical modalities now for treating breast cancer, and all these are still under research, and they are not yet approved as to be as in the guidelines, but only restricted for those patients who refuse or reject surgery, and the one that have stage 1 disease in old patient with node negative. These are some of the studies that have been performed and promising in a sense, but not yet fully not yet fully confirmed by all the authorities. And just wanted to highlight there are the other things that the modalities I'm talking about are the radiofrequency ablation, the laser ablation, the cryoablation, the HIFU. All these have been tested and still on research, but are not yet included, as I said. This was a comment. Thank you. Any further questions?
Yes, please.
طيب بعديه يا فندم محمد.
My question for Dr. Ahmad Raha. First, welcome to Egypt. I would like to ask you about a problem or an issue which facing us in our daily practice in MDT sessions about occasionally detected sclerosing lesions or sclerosing adenosis within the biopsy. Can we categorize these sclerosing adenosis as a P3 or P2? And for management, P3 without atibia, so I go forward VAB biopsy or excision. Thank you.
Well, sclerosing adenosis is benign. Sclerosing adenosis itself is part of fibrocystic change. Sometimes the fibrocystic change in some patient very florid, and it can cause mass lesion. But as long as you don't see the elastosis within the lesion itself, and it is just a sclerosing lesion, and in worrying cases, you can use myopsylar marker. If you confirm it's sclerosing adenosis, it is benign. Because you can have nodular sclerosing adenosis and it is benign. The issue of B3 when you have complex sclerosing lesion. When this one you have elastosis and entrapped glands and it can overlap with other entities. This is the B3 where you need to have vacuum assisted excision or further treatment. It's benign. Sclerosing adenosis, even if it is mass lesion in the in imaging, is still benign. You can accept nodular sclerosing adenosis. But when even if it is 1 centimeter or 1.5 or 2 centimeter, and it is complex sclerosing lesion, in this case we have to take more tissue to excise the lesion.
Okay, thank you.
Thank you.
I think this will be the last question. So, yes, sir.
Thanking the organizing committee for this nice and illustrative conference. My question to Dr. Sharif, surgery. What is the concept of the Egyptian patient to accept prophylactic mastectomy? Number two, is any publication done for prophylactic mastectomy or oophorectomy? I think because the concept of patient to accept, I don't know in Egypt what is any publications, or to accept prophylactic mastectomy in case of BRCA1, BRCA2 negative positive patient. Follow up.
I'm sorry, I think you are addressing Dr. Professor Sharif.
Sharif, yes, surgery.
Sharif Naguib. I think he's not here now for the time being. So any surgeon would like to answer this question.
We have a very eminent onco surgeon interested in breast surgery. أستاذنا العظيم أستاذ دكتور داود التواب. If you wanted to answer about the role of surgery in BRCA mutant patient.
Okay, I would like Dr. Sharif should be here, I think, to answer the question. But for BRCA patient, it's very important medical legal issue, as you said. The surgeon should not push the patient to do the surgery. It should be her choice. You have to describe to the patient all the consequences and the statistics as presented by Dr. Sharif, and she should be the one to choose doing the surgery, not you.
How far the Egyptian patient will accept to do a prophylactic mastectomy?
Actually, not much. In the United States, it's very common operation. They do it a lot in the United States, a lot of mastectomy. But in Egypt, no much patient accept.
Thank you.
Thank you, sir. At the end of the session, I'd like to thank our eminent speaker, our figure co-chairman, and to close the session for break for half an hour, and then to resume the conference. Thank you.